All right. Good morning. Good morning, everybody. Go ahead and get started. I don't want to get too far off schedule to get going. So welcome. Welcome on behalf of Emory and our partners here, the Partnership to Fight Chronic Disease, on our symposium on prevention and treatment of chronic disease in the Southeast. We look forward to a very robust discussion. As you know, chronic disease in the United States accounts for 70% of mortality. 60% plus of Americans have at least one chronic disease. Those numbers continue to rise. So it's a driving factor in the growth in Medicare, Medicaid, and private health insurance spending. The Southeast, which is, I think, why this symposium is timely, is really hardest hit. If you look at the numbers here in the Southeast, the underlying social determinants like poverty, food insecurity, the lack of health insurance coverage, all contributed to this. That's the bad news. The good news is that for our proceedings today, it presents the biggest opportunities for us to come together on a research agenda and identifying areas of change. Fortunately, we have our partners next door to CDC, who's focused obviously on this issue for years and will continue in one way or another to focus on these issues as well. So it certainly strengthens our ability to make these changes. But what we're all doing here is identifying the critical role for collaboration between the public sector, private sector, academia, health insurance plans, public health departments, and so on. We are very well represented here today. Academia between Emory and Georgia State and Morehouse. So thanks to our Atlanta-based friends, the public health community is here as well. So thank you for that. Want to identify and introduce him in a little bit. Kevin Sia from the Doris Duke Foundation. They've graciously provided the funding to do this and really to build a research focus coming out of these symposiums around more effective ways of identifying opportunities to do new research, but connect it to local communities to make a difference. So to get things going here, I am more than happy to introduce Ravi Thadhani. Ravi is the Executive Vice President for Health Affairs here at Emory University. He's also the Executive Director of the Emory Health Sciences Center and the Vice Chair of the Emory Healthcare Board of Directors. He did do a little digging. He kind of has this in his bio, but in terms of research portfolio, a lot of what we do here, he has done work on for a long time period on kidney disease. And so that's one of his passions, is focusing on kidney disease research and pre-eclampsia work. And so he's done several clinical trials on this. So he's obviously, we focus on his really difficult job he's in right now as running a major health center, but also he's a perfect person to open up given his research interests along these chronic disease fronts. So without further ado, I'm going to stop talking and turn it over to Dr. Thadhani. So thanks for joining us.
And I'll just say a few words and, of course, hand it over to our great colleagues at Doris Duke. My father was on dialysis for 10 years. If one has to think about chronic diseases, kidney disease is one of them, and I know it's among the list of chronic diseases that most people think about. The end stage of chronic kidney disease is dialysis, and to be on dialysis for that long period of time is a challenge, as one can imagine. But in that context, when you think of other chronic diseases, whether it be diabetes, hypertension, inflammatory bowel disease, and on, there really could be no better time to think about managing chronic diseases than now. The ecosystem demands that we pay attention to it. We have a population that's susceptible and increasing, and the prevalence of these conditions is only going up. Ken highlighted some of the statistics in this particular area, meaning writ large chronic kidney diseases. And of course, when you look at those amazing maps from the CDC and those, I think, heat maps, they call them, and look at the brightest colors. As Ken highlighted, the Southeast tends to light up for almost every one of these particular conditions. So it's no surprise that, one, we are obviously focusing on that, as Ken said, in conjunction with our partners from the CDC and our local expertise with Morehouse, Georgia State, and others, and of course, Doris Duke in that capacity. The other, of course, item that this area brings up is social determinants of health, understanding that we can look at these conditions and the prevalence of these conditions as they go up and realize that it's too short of a time period for it to be genetically driven, although there's a predisposition, and realize that we can't address these kinds of conditions without looking at the ecosystem and the world around us. And how does this group and other groups, of course, impact and play a role in modifying in a healthy way that ecosystem? And I think the health systems are guilty as charged. In other words, we typically don't pay as much attention to those measures and factors, but again, could not think of a better time and a place and group really to address those kinds of matters than this group, and now being such a critical time with these particular conditions. The economic trade-off is massive, just given the amount of the GDP to healthcare and what fraction of that, as Ken said, goes into managing chronic diseases. But aside from that, of course, the burden to patients and the burden to families is not inconsequential, and only becoming much more dominant at a time when health systems, including ours, are struggling to keep up. And the payer environment is a challenge, and meeting almost an infinite demand for these conditions is incredibly difficult. So it's forcing us to, of course, also be more efficient, more targeted, using technology and thinking about alternate ways of delivering care to manage this growing prevalence and growing burden of chronic disease. And so towards that end, we have, and I'll end with this, really some superstars in the area of technology here to think about how do we focus and streamline our efforts to those individuals that need our interventions the most, and more importantly, what interventions can we actually place that move the needle and create an inflection in those patients at the highest level. And so we're blessed here at Emory to have, and our partners as well, to know that we have expertise in those areas as well. So Ken, thank you for that. I look forward to the discussions.
I appreciate the remarks. Yes, it's the major challenge of our time, chronic disease. No question about it. So if you look at disease burden, if you look at what I spend a lot of time on, healthcare spending and budgetary levels of spending in the Medicaid and Medicare program, realistically, we're not going to make a major change in those programs unless we do something about reducing the prevalence and incidence of chronic healthcare conditions. It's just the predominant factor that dominates spending in those two areas. I'm going to ask our sponsor and our partner in doing this work, Kevin Sia. Kevin is the Senior Program Officer for Medical Research at the Doris Duke Foundation. And I'd love to have him come up and sort of give some perspective from the Foundation's perspective on the set of symposiums. Just so you know, there are multiple ones of these going around the country. So there's one here, there's another one over at UAB, I believe, and Morehouse, I think, as well. So we have a couple of them locally, little different takes in terms of the focus of what they're doing. But Kevin, how many did you fund? 18? So there's 18. And it provides a great opportunity for really taking these conversations and pulling together across these different settings and coming up with really, I think, a very exciting, robust research agenda and sort of a plan for action. So I commend the Foundation for putting this together, and I'm going to turn it over to Kevin.
So thank you, Dr. Thorpe, for organizing. I want to thank Emory and Partnership to Fight Chronic Disease also for hosting. as Dr. Thorpe mentioned, this is one of 18 symposia across the country occurring over the next 3 months. The Doris Duke Foundation are supporting this symposia together with the collective to strengthen pathways for health research. So I would be remiss if I didn't also thank my colleagues at the American Cancer Society, the American Heart Association, Burroughs Wellcome Fund, the Conrad Prebys Foundation, Dana Foundation, the Donahue Foundation, Robertson Foundation, and Susan G. Komen. So the Doris Duke Foundation's mission is to build a more creative, equitable, and sustainable future through support for initiatives in arts and culture, nature, and health and well-being. The initiatives are rooted really in our desire for long-term impact. So we invest in ideas in the fields in which we work in over the long term. I would also be remiss if I didn't say that I am an immunologist by training. I trained actually across the street at the Emory Vaccine Center. And I say that just to say that the topics today are not my expertise. I am not, for instance, a clinician. I am not a hospital administrator. I am not a health services researcher, community health worker, or public health professional. My role today in the few minutes that I have is to share a bird's eye view of what motivated the Doris Duke Foundation and the collective's investment in the slate of 18 symposia, which we're calling the Strengthening Pathways Symposia. So at the Doris Duke Foundation, over the last more than 25 years, our longstanding support for medical research really sharpened our appreciation for the spectrum of approaches, research approaches, and abilities that are needed to translate knowledge into healthier lives. And so the spectrum goes from the understanding the research to understand the basic functioning of cells, all the way to research to understanding how humans interact with their environment in health and in disease. But the system of scientific innovation has dichotomized the spectrum into essentially 2 spheres, basic and applied. This has created a tension over the years and kind of hierarchical jockeying that it is one or the other that deserves further investment for improving health, or that it is one or the other that holds higher scientific value. So we in this room, of course, know that this is not true. All research has value. But we also know this only in the abstract because it plays out differently in practice. The Vannevar Bush paradigm and the endless frontier paradigm set up almost 80 years, or right on the nose, 80 years of what my colleagues are calling the miracle machine. Our investments in the medical miracle machine has built pathways that facilitate the production of the outputs that are our society's crown jewels. So I'm talking about vaccines, statins, cancer immunotherapy. But we are at a historic moment where institutions and the social compact are fraying. Perhaps it is fraying because the medical miracle machine has not worked as well as it should have for all that it should have. At the Doris Duke Foundation, we believe that there is an undertapped frontier of innovation in advancing health through research into disease prevention and into the improvement of the delivery of care. I am not simply reinforcing a flipped hierarchy, but simply stating a belief that perhaps we could start to renew these fraying social compacts between science and society if we can imagine what it would truly take to hold prevention and care delivery research in equal value to the research for drug discovery. There are many tough but necessary conversations that remain. So at this moment in our country, as the scientific enterprise is being reconfigured, these conversations are as timely and relevant now as when the Doris Duke Foundation and the collective set out to support these symposia back last year. So we set out to elevate voices and ideas that offer the opportunity to improve human health in a different way than has been familiar to those investing in drug discovery. We'll document, of course, the ideas that are raised through these 18 conversations, and we'll share them widely. We are particularly interested in learning how these research questions could be better supported and moved into application. So we could see drug discovery in one view as the commercialization of the research of fundamental biology. In another view, it's actually also can be seen as the application of that same research into scale. So what is the analogous pathway for disease prevention and care delivery research? How could those pathways be built or strengthened, made clear and easy to navigate for those researchers and investors within those fields with interests? Who are the different stakeholders and investors who support knowledge generation and its application? So I'll just end to say that under the great uncertainty that we operate in today, the future is certainly not destiny, that we have now a quite unprecedented opportunity to shape how research could be funded, conducted, and applied differently. And it starts with conversations like the ones that are happening today, and the ones that'll be happening across the country in the next 3 months. And we could offer a vision for improved research enterprise, to let go of traditional models, to try to think differently, to advance research that'll save and change more lives more quickly. And with that, I'll just thank you in advance for all that we shared today, and thank you for having me.
Thanks to Dr. Sia for sort of laying out our challenge. I thought that was very clearly and quite articulately put on sort of where we are and what we're hoping to get out of this symposium, but also other symposium like this across the country. I just want to spend 2 minutes and recognize that the Duke Foundation is being assisted by Mathematica. I don't know if you wanted to just say 2 things or 2 words or just.
Hi, my name's Danielle Witcher. I work at Mathematica, so I'm here coming in here from DC. Our role in working with the Doris Duke Foundation is to create a summary of each of the symposia that's happening across the country. And then once we have all of these summaries, we're going to look across them for themes. And our goal in identifying themes is to put together a blueprint for action that all of the symposia hosts will discuss after the symposia have happened, so we can make some decisions about what are the next steps in terms of tackling some of the problems that have been identified. I think that's it.
Okay, well, thank you. Thanks, Danielle. No, obviously, you can just leave it on. Like I know what I'm doing up here. That's as my colleagues over here found out, that's a really bad assumption. So I said, if we didn't have our IT people up here, you'd see stick figures and other types of things. So that's definitely not my forte. But now we look forward to seeing the summary across these a different symposium, and I think it's exciting to really pull together across these different settings. Each of, like I said, looking at slightly different angles and different focus on this issue, but really to put together a call for action and an action plan that we can all look into and chip into and really guide some of the downstream research with the Duke Foundation, but also, as Dr. Sia mentioned, a whole set of partners that they're working with, including our local friends here at the American Cancer Society that obviously are very interested in these sets of issues because that's what they deal with every day. And so I think we can do a service in terms of identifying themes and identifying factors for us to study on and explore to really do a better job of setting the stage for better prevention, better earlier detection of disease, and more engaged management of patients with multiple chronic conditions that are clinically complicated to work with. These are people that have anywhere from a behavioral health disorder to different forms of cardiovascular disease and so on. So they are complex and it requires a very specialized a way of interacting with them in terms of care delivery teams and interdisciplinary teams and so on. So that's going to be part of our focus. With that, you can see by the setting here is that we're going to have 3 panels. Like any panel, we had some last minute changes in terms of people coming and going. We had some original folks from the CDC that were going to come. We had a representation from the CDC Foundation, who unfortunately had a family emergency late last night that we found out about. But we have in all these panels a very diverse set of people and very diverse set of perspectives. So I'm going to introduce the moderator for the first one, and I talked with Dr. Lin. He'll introduce the rest of the panel himself. But we're really, really happy to have Rodney here. He's the Dean of the Georgia State University School of Public Health. I had the opportunity to do a talk down at Georgia State a little bit ago, where we spent some time talking about these issues. So we're just really happy that Dr. Lin could be here. It's a perfect topic for him because the focus of his research is really on chronic disease prevention. So we're excited about that. And as you'll learn from Dr. Salinas that there's going to be some common interests here, since Dr. Lin's interest is also on childhood obesity issues. So I think it should be a good first panel. Without further ado, I'm going to have Dr. Lin come up, and then he can introduce the first panel. So thank you.
Thanks so much, Ken. It's a pleasure to be here. I want to thank you for inviting us, and thanks for having Georgia State represented. We really have lots of opportunity to work with our partners here in the Rollins School of Public Health, but it's always good to formally come together as well to work on the issues we care most about. We've got a great panel to start us out, Overcoming Crisis Management Mode. And as Ken said, we've got a wonderful panel for you. And so I'm going to ask each of our panelists to come up as I give you their names and titles. So Teresa Jacobs is Medical Director for the Georgia Primary Care Association. Nitu Kashyap is the Vice President and Chief Health Information Officer for Emory Healthcare, Emory University. And Danielle Salinas is Chief Medical Officer and Chief Quality Officer, Emory Healthcare, as well, an assistant professor in the Department of Family and Preventive Medicine here at Emory School of Medicine. So if these folks would come up and join me here, please welcome them. And we're missing Teresa, but we'll go ahead and get started. So what I may do is, just to start us out, invite each of our panelists to just talk about their background and their work relative to chronic disease and fighting chronic disease, and then we'll jump into some Q&A after that.
Good morning, everyone. Excuse me, I'm Dan Salinas. I'm actually a pediatrician living in the adult world because I deal entirely with adult medicine. So I'm involved on a day-to-day basis with what is called the Population Health Collaborative at Emory Healthcare. And Emory Healthcare, the Emory Healthcare Network, Emory Primary Care, and our population health partner, Guidehealth, we work together on a daily basis to make sure and to drive the appropriate care, appropriate preventive care as measured by payers for approximately 400,000 patients. So my approach to what we're discussing today is somewhat pragmatic, but it is grounded in the knowledge that as a pediatrician, and actually the reason I went into pediatrics, is that the opportunity to impact health longitudinally really begins in childhood. Now, that's a loaded statement, and no one does better at preventive care for children than pediatricians. So from the age of a week all the way to the age of around 13. Kids go to the doctor regularly, they get their vaccines, everything happens beautifully. And then after that, not so much. And so when I say not so much, I don't mean that dreadfully. I'm just saying that the ingrained patterns of the appreciation of preventive care and healthcare and that it starts to drop off and it starts to wane for a lot of different reasons. The point, though, is that there is hope. And while today we're here to talk about chronic disease, there's an opportunity to look longitudinally, I think, beginning in pediatrics all the way into adulthood. There's a way to look longitudinally at this. And I think that the time is now. And I want to end, and I'll hand it over to Nitu. Back about 10 years ago, I read a book called The Healing of America by T.R. Reid. My book was written in 2010. And it was given to me, I was the CMO of the Children's Hospital here in town. And it was given to me by the CEO, given to the entire executive team. And in that book, T.R. Reid lived all throughout the world. He lived in different countries and experienced healthcare in different countries. And I think he broke his arm in one of the countries and had to access the care, and it was phenomenal. But there was a graph he showed that struck me, and then I'll tell you the rest of the story. What struck me was the amount of money that we spend in the US on care compared to the outcomes. In 2010, we were last. At the top, Australia, Sweden, Germany, we were last for the amount of money spent versus outcomes. Today, I pulled a report by the Commonwealth Fund that showed similar data through 23, and US is last. We're still last. So the point of all this is we've got an opportunity. The good news is we're not starting from ground zero because we have systems built. We live these systems every day that drive better care for adults, in our case, through our network, through preventive care, et cetera. We're not starting from zero, but we do have a ways to go. But I think that this is the right way to do it. So thank you. Nitu?
Good morning, everyone. I am Nitu Kashyap. I am a recovering primary care physician. So what Dan couldn't finish, we're supposed to finish in the adulthood. And I will share one thought that as Dan was talking about, that up until 13 years ago, there's great primary care and preventive care. And then there is almost none, probably because mom's no longer in charge. Think about it. My role here as the Chief Health Informatics Officer is to be that interface between technology and our care providers, as well as technology and the patients. We forget that in this whole equation that we're talking about managing chronic diseases and preventive care, where's the patient in this conversation? And this is where the new frontier that we are talking about, and you will hear through the day, what some of us are doing in the space of population health and reaching out to all of 1.6 million active patients at Emory. We know more about them than we think. Data is here to help. We need the ideas flowing so that we can do what we need to do. My interest is in clinical decision support, which primarily was thought about as providing the right information at the right time to the right clinician in the right workflow, right? We've taken the leap of faith into that next paradigm of saying, can clinical decision support be patient-centered, patient-centric, patient-facing, patient-oriented clinical decision support? So I think we have an opportunity here to understand that whole continuum of the from where it comes and where it goes and where it needs to land. We can recognize conditions, we can recognize patterns, we can predict patterns, but at the end of the day, there is an individual on the other end, and how do we impact them? There's social behavioral health. We talked about social determinants earlier. There is a lot of data that we have access to, and I truly feel that we're at a place where we can make a big difference by joining hands. So thank you all for being here.
Thank you. Let me ask both of you to think about following question. What do you see as the most significant barriers to really that are preventing health systems from shifting their focus to and resources to upstream prevention and interventions in the current context?
I think we're about to say the same thing. I think it's the misalignment of incentives, both on the healthcare system side, the provider side, and then the patient on the other end. We pay for acute care. We demand acute care. No one's demanding preventive care services in the community. And our payers certainly aren't opening up their purse strings or recognizing that that's an important thing. Although in Dr. Salinas's role in value-based care, we do see that trend shifting, but the vast majority of our finances are still driven by fee-for-service care or acute care. And that's where our primary focus has been, aside from my colleagues in primary care and family medicine, I would say, and maybe the pediatricians. But however, that someone once said, follow the money. I think you'll find your answer there.
So I'm going to paraphrase a quote. It's Desmond Tutu. And Desmond Tutu said, at some point, we have to stop pulling people out of the river and go upstream to determine why they fell in. So Dr. Lin, to your question, it is definitely the right approach. And patients and providers, because of the way providers are reimbursed, prioritize acute care. It's not meant to sound pejorative, although it may. It is the cash engine. The cash engine is acute care treatment. So the shift that is underway and that we're at Emory Healthcare with Guidehealth as our partner, that we are fueling is a shift toward what's called value-based care, where you're paid actually better if you prevent disease than for treating acute episodes of disease. And this shift is underway, and it's actually in different parts of the country. If you go to certain parts of the Northeast, if you go out to the West Coast, they've been successful at this. Of course, if you go to other countries, they've been more successful at this than we have. So this shift is already underway. I think the challenge for us is to determine how do we make that happen? And how do we educate patients all the way down to the 5-year-olds that doing this preventive care thing is what we need to do?
Yeah, I mean, the next question is about realigning incentives, which you sort of started to touch on there. When we want to change behavior, we can reward people for doing the things we want them to do. We can penalize them in some way, create disincentives if they engage in the things that we don't want them to do. So I wonder if you could sort of extend that and sort of think about like what sort of how do we realign the incentives so that it makes sense, not as a pilot, but at scale? How do we scale that kind of change so that we have prevention happening, nationwide?
Well, the amount of money in the healthcare system, it is finite. So the payer systems, they have one piece of pie, but they're willing to distribute that pie in a way that recognizes and bonuses, if you will, good preventive care. The key is, how do we get that care to the level of the patient? And the patient has to be a participant in this. So, for example, the use of a drug called statin, the statin drug reduces cholesterol and bad fats in the blood. That drug is proven in patients with diabetes and heart disease of any type. It's proven to reduce untoward other diseases like stroke, for example. It's proven. There's science that says but yet patients refuse to take them. It's probably the most difficult preventive care measure that we have, that we are driving. And the payers have recognized that it's really important because the use of statins and how we're measured, it's triple weighted. So compared to getting a mammogram, which is rated 1, the use of these drugs it's triple weighted in the scheme, in the payment scheme. But getting patients to learn or getting patients to agree to take this, it's like pushing a rope uphill. And why is that? Well, Dr. Kraft and Dr. Kashyap and other primary care doctors, they talk to these patients, they write the prescriptions, but the neighbor says, oh, if you take that, your Achilles tendon's going to rupture, or you're going to hurt your muscle, or something bad is going to happen. We're being out communicated by others in this. Nitu?
Yeah, a long time ago, in years past, when I was a med student, they taught us to a principle that says make someone's health need their felt need. And I think that's what you're hearing is, has anybody here tried to deter someone from getting an antibiotic for a viral upper respiratory thing, which doesn't need antibiotic? How hard is that? Because people feel it is their need to get it. And we'll talk in a moment about what the drivers are. Has anyone ever come and asked you for saying, give me the statin that I need? They're not feeling it. And part of it is we have that responsibility to get the message out there. Why is it not happening? Why are we getting out communicated? And I go all the way back to, what do our guidelines say? We practice evidence-based medicine, and that's why we know that this is an important thing. But are our guidelines aligned? We see a lot of times when the guidelines are discordant or ambiguous, they're following the science, but the impact it has on the practitioners that follow the lead and the general public who now has access to all of it is that it causes confusion. When something is complex, complicated, and confusing, it must be hard, and it must therefore not be the right thing to do. I'm not a sociologist, but just sharing my own experience on what I've heard and seen. I think we have a responsibility to align our guidelines for evidence-based practice of medicine in this space, and then work towards making that health need the felt need.
How about thinking about the bottom line, the actual dollar? I mean, can payers, as an example, profit through prevention? I mean, what sort of models make it worthwhile for them to invest? And you know, if all payers aren't investing, some are, some aren't. I mean, how does that shape the landscape as well?
I think you're onto something here, Dr. Lynn. So I'll explain. I used to be in the payer world. I was CMO of Blue Cross Blue Shield of Georgia. I will tell you that payers live for the moment. So today's insured patient by Anthem is tomorrow's insured patient by Aetna. And then the next year, they're insured by United. So payers live for the moment. They don't step back and say, I need to make an investment now so that this person will be healthier later on. In general, they're not wired to do that. They have investors. They want to see their return on investment. So our opportunity here, though, is if we were to launch some type of longitudinal study, the way we speak to the payers is to show that what their return on investment would be. And to show that if we do this right longitudinally, take a 35-year-old maybe with hypertension and follow them for a while, you can show a payer that you can prevent the development of other diseases, stroke, kidney disease, other diseases by treating this individual correctly. So we have an opportunity. If we can show the payers the return on investment, I think it would help us. Nitu.
Dr. Lynn, you said something in your question that actually is the answer to what you're looking for. You said something about, do all payers do it? I think if they're all doing it, they're all standing together to see the benefit down the line. But yes, they're responsible for my care January 1 through December 31st. I may choose to renew, in which case they'll see the benefit of whatever help or health care was provided to me, but they may not. Who's the common factor in here is the healthcare provider, the healthcare system, where there's longevity of a relationship. And we in informatics and in the data technology team share that responsibility by providing you with the continuous data stream that can look back and help you look forward. So I think it becomes somewhat our responsibility to do exactly what Dr. Salinas was talking about, is showcasing what's possible. But I've got to believe that there are smart people sitting on the payer side looking at that exact data and coming to a very different conclusion. There are very smart actuarial expertise over there. What is it that we need to do to provide them with the counterbalancing on that? And that's our responsibility. And I think we do have data to showcase those things. For example, for many, many years, the payer claims-based data was the only large data set that we had access to, that we could get large population and level analyses on. Now we have real-world data from the EHR. At Emory alone, we have 1.6 million active patients who have been seen here in the last 3 years. I've got to believe that the data that we have, that we can tap from that, is far richer than what a claims-based data alone could provide. Payers are recognizing that. That's why they want us at the end of the year extract of our clinical data so they can glean that information. And we need to get to that next level and stay a step ahead of being able to say, this is what our data is showing. A population that we provided preventive care for is able to stay out of the hospital, being able to talk the talk that is understood. And I'm conscious of the fact that both of us are sort of putting the payers at a disadvantage. There is nobody representing the payers here, or is there? All right. So let me just say that I used to live in the insurance capital of the world up in Hartford, and we have mixed emotions when we talk to our payer colleagues, but we've also each talked to individuals who mean well. At some point, our systems are designed to fail all of us. And we have a real opportunity to get ahead of that.
May there's one thing I wanted to add along this line. So the payers today are reimbursing us extra dollars, bonus dollars, by providing good pathways to good preventive care for those 400,000 patients that are in our value-based contracts. They are doing that. And so we have, I could name you a litany of 83 measures that we have that we are, which is a problem in and of itself, but 83 measures that we have that the payers are holding us to delivering. And basically, and when you look at the top 10 or 15, it's the things you would want. It's mammography, it's colon cancer screening, it's A1 diabetic management of diabetes monitoring, it's monitoring of high blood pressure. It's all the things that you want. They are paying us more if we deliver that, or if our network, the doctors, deliver that care. But getting it to happen is the problem. And at times it does feel like we're pushing a rope uphill. But at Emory Healthcare, at the Emory Healthcare Network, in participation with Guidehealth, and I keep pointing at Sanjay because you'll hear him later, he's the CEO of Guidehealth. We have done this past year, we did something short of, it was a miracle. The focused effort we did to be able to show improvements in our what are called STARS results, in our HEDIS, the measures that we're able to use that were measured by the government and by the payers. So it can happen. And we were able to reap the rewards of that, and distributed it to our doctors who ultimately are the owner of the patient. So this can happen. It can be done. So there's hope.
Could I add something to that, Dr. Lynn? So Dan, we're grateful that we only have 84 measures to track because Johns Hopkins,
It was 83.
83, pardon me. Johns Hopkins a few years ago reported that they did 162 measures. So, but they also needed to spend $5.6 million to just calculate those quality metrics, sometimes with extraordinary means because one definition doesn't talk to the other. So if we want that extra incentive that the payers put out, we have to invest upfront.
Very well said.
Can you talk a little bit about models that you've seen, and you may have started to do that, but models that you see that are bridging public health and prevention with clinical care? How do we get more momentum and sort of amplify, do more, implementation of these sorts of models? Can you think about some successes that have been successfully incorporated into clinical care?
There is underway right now a program through Emory Healthcare, through our diversity and equity area there, where they are starting to use, and this, I don't know if anyone's here from the School of Nursing, but this phenomenal program around the use of community health workers. And we have been training, we've probably trained over 100 community health workers. So the use of a non-clinical individual who lives in a community and has said, you know what, I don't want to be a teacher anymore. I want to go into healthcare, but I'm not a nurse. I'm not a clinical person. And they're trained to be community health workers. And there's a focus right now, and it's in the right place, in improving maternal care and maternal child care by implementing a community health worker in the postpartum period with moms in the Hillendale, Emory, Decatur hospital area, moms that have just delivered babies. And they're starting to see results where moms are able to get to someone more quickly when they themselves have a problem or their baby has a problem. So that's a really good example of a public health approach and the effect it can have on real live clinical outcomes.
I'll make maybe two themes here. One, of course, that grassroots partnership is critical in a lot of different ways. I've seen that pan out in public health centers in India, where I did my medical school, where you have an outreach worker who's assigned a group of homes or a location, and they're responsible for all health of that family. So being out in the community rather than the community coming to you for care, because that will only foster episodic care. The other things that I've seen examples of that same thing, or rather heard about, is our colleagues across the pond at NHS had a program where they would have young high school or college students manage phone banks to call elderly individuals just to check in on them and have a conversation. What's the problem with an aging population? Is isolation and things that come with it. And an important program that connects two parts of the community together, but the benefits are on the health and healthcare and the expense we see in senior care. And selfishly, if I may, add one more thing that's happened in our very own lifetimes, where we've seen data being released and democratized through the advent of electronic health records and the interoperability that we've seen across them. So previously, where I couldn't see whether Dr. Salinas, who I'm seeing today for his chronic condition A, has had his flu vaccine or not, I have the ability to see that now. I have the ability to see what medications was prescribed by his previous physicians. So those are the things that are happening around us that are powerful. And yet there's a little bit further that we need to go, because they're still in the clutches of episodic care. So a lot of our interoperability systems that I know the School of Public Health teaches about, public health informatics, and this is exactly their domain, it is still in the clutches of episodic care. I can see all of that when I'm seeing Dr. Salinas for his visit, but when he goes back home, I have less transparency on that data. That's the silo that we need to continue to break.
Yeah, about 20 years ago, my supervisor, who we were doing a lot of work on chronic disease prevention, and she walked in my office and she said, "I've been badly misquoted in the media, in the newspaper." And in just this context, she'd been known to be a bit blunt and insensitive. She had spent a lot of years running the state Medicaid program. I said, "Well, what did you say?" And she said, "Well, I'm quoted as saying that the problem with chronic disease is that people just don't die. They, live with these, diseases, and the burden on the healthcare system is just really, really awful." And I said, "Well, problem is that sounds like something you would say." But I think, part of the sort of thinking is about the economic argument here and the burden that it actually places. I think Ken was talking about that earlier. And so I want to sort of move us to sort of thinking about return on investment and how do we actually convince those that can fund prevention to actually do it. I think that until we can actually start to see a return on investment, it's very difficult to convince folks to make those investments. So would love your thoughts on just how do we demonstrate return on investment in these spaces.
When I was at Children's, and it was several years ago when Children's took over the Marcus Autism Center, there's a type of therapy that is known and proven to be very useful and helpful in children with autism. The earlier they're diagnosed, especially, it's called applied behavioral therapy. You've heard of it, ABA. And there was a refusal by the payers to pay for it. And so the task that Children's had was, how do we prove to the state government that there will be avoided costs later on if they will pay for ABA? And so they were able to create a model. I mean, it was a scientific model that, because it's hard when you're looking at avoided costs, that's very hard to say we avoided this ER visit by doing this. It's just hard to do it. But I don't remember other than using predictive modeling, I don't remember how it was done, but that is what we need to do, is to create a model that can show if we avoid these things over here, we'll save all of this money by investing in this particular thing right here. So it's getting down to using a cost model to demonstrate return on investment. It's not easy.
I'll have to agree with you on that one. I'm just pondering on things that you said. It's hard to, well, it may be easy to show correlation, but it's hard to show causality. But we have that opportunity right now, even within I guess in this room, there's public health researchers who work with very large data sets and predictive modeling, who can actually help us do some of that work to being able to make that assessment. And as you were talking, it made me think about the very obvious thing that we're doing here. We're doing such a good job at managing acute care that we are seeing more chronic diseases, because what's our life expectancy now versus what it was 50 years ago? So granted, we are seeing things that we'd never seen before. And the community that's in this room recognizes what the model for the future looks like, because you can tell us what the population distribution by age is going to be 20 years from now, and what conditions, if nothing changes, we will have. I'm sure people have done that kind of work, but it's not talked about as much. it comes up every now and then when you talk about Alzheimer's care and why people are so focused on care for the elderly and Alzheimer's disease, because we see the burden. I think that same level of conversation can happen further along. Yes.
So I guess my question is, all this modeling, would seem that the incentivization, especially movements towards value-based care, must be, assuming things remain equal politically, but driven by Medicare to really enforce and incentivize all of these earlier temporal decisions in someone's life. And I'm curious if you have thoughts, or if anybody has really talked about the role of Medicare in this, not prevention at the point of when someone converts to a Medicare beneficiary, but before that as a way to offset the major cost.
That's a brilliant connection, Brandon. Here's one answer I'll give you, because the map was already created with the Affordable Care Act, like it or not. It's not a political thing here, but the map was laid out, and the Affordable Care Act adopted the IHI's triple aim. You deliver better outcomes, better experience, and reduce cost as a part of this path. It will be nirvana. So it's there. I just don't think we have fully realized. And in fact, accountable care organizations, as you all know, came out of that. And they were geared to do all of this. And we're in the middle of it through our Emory Healthcare Network, where we have an ACO as well. So the path is there. Medicare knows this. I think they know it better than the payers know it. So it's there, but how do we use that and leverage it and resurrect it? Because I believe it needs to be resurrected.
That's a great connection to make. First of all, I think there's two themes in there that I'd call out. One is that CMS is a big driver for things. So a few years ago, when we had lung cancer screening conversations on what is covered, people looked to CMS and what they're going to cover. Every payer had their own categories, and then they sort of kind of aligned to where CMS landed. And so CMS leads the way in as being one of the bigger payers, right? The others will follow. The challenge with CMS that is very apparent, the way you stated it, so I'm almost restating, is that CMS is beholden to a higher authority, and that changes every 4 years. So it becomes an entity that can and should be able to look longitudinally, but is sometimes limited by other external pressures, let's say.
If we think about long term, and I like the shift to thinking about the federal role, many of us, our organizations, payers, are thinking in the short term, is what I've heard you say. If we think about the benefit of greater longevity, greater health and greater quality of life, those benefits accrue to employers, the overall economy. And so is the federal government best positioned to make investments in prevention? Historically, we've been among the lowest among industrialized nations. What is the role for the federal government as it relates to investing in prevention? Certainly, you talked about the Affordable Care Act. There were certainly some elements focused on prevention there. What more should we be doing, and what is the role of the federal government as it relates to ensuring that we're thinking long-term and investing long-term in a way that benefits the whole nation?
Sure. The deep pause says a lot of things in of itself. Feel free to read between the lines there. I'm torn in how to answer that one, only because there's a responsibility that the federal agency or the government can do for us. But there's also things that we don't need the government to intervene on. And there's a happy balance in there somewhere. So the government can provide things like clean water, electricity, high-speed internet, and those kinds of things individuals cannot do. Affordable housing, preventing I don't know, pollution and those kinds of things is where you need the power of the government. There are things that we can do at a different level. And I think of the responsibilities that employers has. How many of what part of our population has employer-based insurance and coverage, right? And I've seen that in the organizations I've had the good fortune to work with or work for and serve. They take that responsibility as the health of their employees, but in general, they are the drivers of preventive health in a lot of ways. You'll probably hear from my colleagues later today about some of the programs we have at Emory Health for our employees, which some of them have needed a federal mandate, flu vaccinations every year. Think about those. Years past, we saw COVID vaccine requirements, mandates, and then no mandates. But we also have smoking cessation incentives, mental health facilities that we can reach out to without punitive impact from the employer. I feel there's a role for non-government agencies in that space as well.
There's a saying when I was in the payer world, and it still exists today, as CMS goes, so go the payers. So CMS is in a position, the Center for Medicare and Medicaid Services, they're in a position to lay the groundwork and to be an example for what should follow. And Ted, I know you're very familiar, the U.S. Preventive Task Force is a treasure trove of laying out what should happen and what type of preventive care should be given at what age, et cetera. So it is all there. The issue is, how do we rise it to prominence? Because I don't think it's to the level of prominence that it should be, but it's there. And as CMS creates it, the payers ultimately do adopt it, and then everyone gets it. So there's just something missing, some kind of glue, and I'm at a loss for what that glue is.
I'll tag on to the USPSTF thing just for a moment, something I said earlier. So USPSTF, in primary care and family medicine, we live and die by what the USPSTF said because we trust that agency. But if you talk to colleagues in specialty care, they have their specialty organization, which have guidelines that are sometimes discordant. The movement in the past few years we've seen is a big relief to those of us at the front line of care, because the age of, say, when a mammogram should be started for an average risk in woman, or the frequency of those mammograms, women's health care, all of those things had some discordant. Colon cancer screening, whether we should do a prostate cancer screening with a PSA or not, those are the things that cause a lot of confusion in the minds of the care providers. And when we try to explain in the form of shared decision-making to our frontline patients, they don't feel the confidence that they need to feel, because it's something that this is how it's going to be, because this is what the evidence speaks. So we, in our own healthcare community, do ourselves a little bit of disservice by not aligning around a recommendation. I don't know what the solution to that is, except sitting across tables and having that conversation, the difficult conversations of saying science says this, and oh, by the way, sociology says this, and therefore we come up with a recommendation. More work ahead.
So I'm going to ask you one more question, and I hope it's okay. I'm going to invite all of you to ask questions of our panel after this. But just wondering, what strategies do you think we can use to shift both provider and public mindset from sick care towards a more preventive framework? Any thoughts on that? I mean, we feel it seems like we're stuck there.
I think there's an opportunity for us to, and you can do this through demonstration projects, but take a healthcare system like Emory Healthcare, for example. We have a big opportunity, and we're doing this right now, to show that if we can get our own house in order, what effect that can have. So by providing the environment for our employees to get good preventive care, to focus on lifestyle management, to give the tools to do those things, and to show that as a healthcare system, we've done this and we are walking the talk, I think is a really big thing that can be done. And that can be done in little demonstration projects. And before you know it, you coalesce those together and you've got proof that this focus can work. I think it can be done.
I have two words that I'll share with you all, and one is trust, and the other is nudge. Trust is the currency in healthcare. This is what we call the patient-physician relationship, my relationship with my employer, with my colleagues, my friends, my neighbors. Trust. How do we build trust? There's that piece of work, whether it's through the grassroots efforts you're talking about or showcasing what we're doing within our own smaller communities. So those examples, I think all of those go to bring develop that trust. Now, trust brings confidence and therefore probably better adherence. And I say probably because we have to show the evidence there, but it certainly is understood as the currency in healthcare is trust. And we know that there is data to show who do people trust: their banker, their employer, their healthcare provider. If you wanted to rank those three, you could probably come up with your own ranking system, but I can guarantee you a majority of you will think, well, among the three that I mentioned, it's probably the healthcare provider. The next thing I will mention is nudge. We've seen that in other areas. Behavioral economics has shown us that if I tell people like 23% people have already registered to vote, right? The rest haven't. But it makes us follow the leader. Using those kinds of approaches to healthcare, I think it is time we do that. Marketing does that well. Like, how do you sell, pens to people who are using laptops and computers? Pens are still selling. So we have some opportunity to learn from others in that space and plant those nudges along the way that make people the health need to the felt need going forward.
Thank you. I'm going to open it up and invite all of you to pose any questions that you have for the panel. There's a microphone here. Thanks to Ted for his willingness to help out.
First of all, thank you very much for the excellent panel. You guys have set a tall bar for the rest of us for today. My name is Warren Jones. I'm here from Mississippi. Two quick things. I really appreciate your talking about the USPSTF and the unique problem it poses. It looks at a system-wide approach to potential measures, but we've got to interpret that at what happens to the patient-facing use of those measures. And that's where the disconnect comes in. The problem is the payers often decide which is cheaper for them. Okay, not necessarily what's better for the patient or better for the data. Secondly, there was a time, long time ago, when businesses didn't mind sharing some of their profits. They even had profit sharing with their employees. Now it's just a race to see who dies with the most money. So the willingness to do anything that would help their employees is something that they're not looking to do. When I ran my state's Medicaid program, those that were employed, I tried to get them to engage in physical activity one Friday a month. And businesses came out and opposed that, not recognizing that one Friday a month of activity improved their quality of life, their longitudinal life, and a better work environment for them. So the narrow-mindedness, and I hate to sound so caustic, of the business world of having to be the richest today is one of the reasons why paying for prevention is a challenge. They refuse to accept the mantra that a rising tide lifts all boats. And when you guys come up with a way for us to get that, call me and I'll try to join you in getting that message out.
Well said.
Good morning. My name is Adaya Katulaman. I'm an emergency medicine physician here at Emory. And my question for the panel really relates to this idea of meeting the patient where they are. We talk a lot about how a lot of the focus is in acute care. And every day I see patients with strokes and heart attacks and kidney disease, but I also see people with uncontrolled hypertension and diabetes and obesity. And while I have great training in managing the emergencies, I don't have great training in treating those chronic diseases that cause them in the first place. So I also now went back to the training to do research to better address that problem. And my work is really focused on training the next generation of emergency medicine doctors to do that preventive care. So my question for the panel and for anyone else in this room really is, what role do you think the emergency department can play in better preventing those chronic conditions, considering that the patient is there, they're willing, they're motivated, they're waiting? We screen everyone for high blood pressure. Every single person who comes to the emergency department, we screen for hypertension. So just curious to hear your thoughts.
That is a great question. And may I throw urgent care centers into that? Because that's two places where especially younger people go for episodic care. The opportunity is huge. And Dr. Kashyap is working hard, and others in this room, to create those connections. But every time a person is seen for healthcare should be an opportunity to promote preventive care. Every time. But you're not, well, in Epic, you're wired to do that. Inside of Emory, you can do that because on the storyboard, you can see gaps in care in that. But you're seeing patients that fast. So this is an opportunity, it's huge, to create the method so that in ERs and urgent cares, when there's a preventive care gap identified, a person is either given an appointment or they're directed to fill it. So that's a big opportunity we need to capitalize on.
Well, I want to say thank you for the work that you do. And the fact that you're having to do acute care and trauma care alongside preventive care makes me feel like we failed you. The fact that an individual has to be in the emergency room should not be the norm. But the fact is that emergency rooms and urgent cares are becoming the primary care provider for a large proportion of our population, especially in certain demographics. And that's unfortunate. But it also spells an opportunity for us. Every contact is an opportunity. If you look around the emergency rooms in the past few years, and I don't know, I think it came to the fore with the pandemic, but it existed before too. How many boarders do you have in your ED? People who need an admission and can't get an admission. What's your average wait time in the ED? That tells you that this is an opportunity where you can impact change. Probably not for the sickest who has other acute conditions, but the relatively well who are receptive at that point in time for a timely intervention because they've felt the need enough to be in the emergency room. So it's an opportunity for us to tap into that lag time in that waiting room. What is it that we can offer to them? Can we connect them with the system? An easy thing a lot of people are doing is connecting them to a primary care referral line, for example. But that still means you have to go somewhere, and that may not happen. There are other models where states have offered or required HIV screening, for example, for everyone that walks in through the emergency room. So there's pockets of things that we're trying to do. There are areas where we have community health workers doing social determinant screening to then plug you in for the next follow-up appointment, bite-sized chunks in care. So work's happening, but I don't know that we have actually solved all of that. But it is an opportunity that we need to tap into.
Another part of the system, you mentioned community health workers, EMS sees in many parts of the country, they don't transport many of the people they see, and they see some of the individuals over and over and over. So thinking from a system perspective about how we can better prepare them to support those that they're interacting with is also, I think, another space. Jim.
I'm Jim Curran, formerly Dean of the School of Public Health. And I'd like to congratulate you and thank you for what you're doing. And I wasn't aware of all of the things you're doing and how you're doing this within the opportunities and constraints of our health financing system. But I made me think of two things. One is you're bringing up the pediatric model. And second of all, why I wanted to be a doctor 50 years ago. The pediatric model, how's it different? Well, of course, there's a different provider mix in terms of specialists and primary care people, but there's almost universal health insurance coverage. So everybody has health insurance pretty much. Number two, is very paternalistic or maternalistic. And so the decisions aren't made by the patient, they're made by somebody who cares and loves for the patient. And therefore they want advice from their trusted doctor. And there's a primary care system. The system is based upon primary care. Now, why did I want to be a doctor? I wanted to be a doctor because of my primary care family doctor. I thought he was a great guy. Anytime there was a health problem, my parents would call him and say, what do you do? Now, I might say, go to an orthopedic surgeon. He might say, go to this, but they exist. And I would argue that the primary care system in the United States doesn't exist, and it doesn't work very well. There's a lot of people doing it. I'm fortunate to have my own primary care internist, but even he is relatively powerless compared to my family doctor in the old days. So the trusted person doesn't really exist for most people. That's why they go to urgent care when they have a cold and all this kind of stuff. And that's a problem. That's a big problem. The other thing is that it's hard to see how we can really do a lot in the future without a universal health insurance system. We don't have everybody insured. You know, you're playing games trying to get the private providers to help out Medicare, and they have Medicare force them to do it. I mean, we can't get Medicare to force people to do anything, really. You know, and the current administration is actually removing a lot of these prevention incentives from Affordable Care Act and everything else. But if you have a universal healthcare system, it forces people to think big and think long term. And it's very, and pediatricians can do that, you know, and can be trusted to do that. The rest of us are very incremental. And my doctor, who died many years ago, would probably lament that. And the question is, how can we get back to the best kind of model where people have a doctor? I mean, who do you call that you can trust? My whole neighborhood of upper middle class people, almost nobody has a doctor, you know, that they can call. They call me and say, you know, a good ophthalmologist. Well, you know, how does that fit into their hypertension? Things like that. So it's more of a lecture than anything else, but I thought I'd say.
And as any good lecturer, I took a few good points to take away from. One, I think in your narrative, you're alluding to the fact that knowledge has grown and medical knowledge, doubling time has gotten smaller and smaller from 17 years to 1.6 months or something narrow like that. How does one keep up? So being a primary care physician, by the way, that's a breed that's not expanding. It continues to shrink every year. More people want to go into specialty care for a variety of different reasons. On the patient side, I have access to the information that tells me that this might be a certain type of a problem that I'm having. So I'm not looking for paying 2 copays to see 2 people. I'll go to one person and pay 1 copay. So there's themes in there that go on to say we're becoming very advanced and science has grown as well. And that's part of the burden that we carry in an advanced nation is we have so much that we can offer that it becomes hard for one individual to carry.
But in TRE's book, every other country had national health insurance.
Yes, and the OECD data still shows that we are at the bottom of the pile of advanced nations and no better in healthcare than some of the nations we think as third world countries.
Oh, question over here.
Sure, thank you. I'm Candace Mateus. I'm with the Partnership to Fight Chronic Disease. I love the analogy of going upstream to find out why people are falling in. And we have, or at least had, political conversation, a very robust public health infrastructure that, really saved a lot of people during COVID. And we saw that, and we saw some flaws as well. But I'm wondering, are we waiting too late? The person has fallen in the river. They're in the physician's office. How do we move upstream and get that? And one analogy I just want to give, when I had children, I was like, wow, this is so proactive. I got, regular visits, emails. I got a dog, and it is a totally whole different. I'm getting emails, I'm getting phone calls, they're due for vaccines. I mean, because it's cash pay, it's a different incentive structure. So I was just curious about, how do we integrate better with the public health systems? And do providers, are they trained on the resources there that they can refer out? Or is there not all on the provider? Are there other things that others in the system should be doing to make sure people have access to that public health support?
I would ask, do any of you have the answer to that brilliant question or thoughts?
My name is Ebony. I'm a public health student here in the School of Public Health. I started when Dr. Curran was our dean. But one of the things that I did, I've also previously, before coming to Emory, I work now in clinical research. I've worked in the pharmaceutical industry. I was a sales rep. I've also worked in patient care and cardiology. So I've worked in different sectors of healthcare, and I hear different perspectives from the public. And you mentioned that people trust their healthcare provider. Well, because I'm not a physician, I just want to speak very candidly and say many people don't. And one of the reasons is something that you touched on. When you start with managing disease because they showed up in your office, that is not prevention in the mind of the public. That is a reaction, and you can only manage the disease at that point. And when the first response is to prescribe a prescription, which I heard a lot of that, that's where the breach in trust begins, because many people in the public don't trust the pharmaceutical industry. So if you pair the fact that they don't trust the pharmaceutical industry and then they go to see their doctor because they're sick, and the first solution is, I'm going to give you this prescription, then that sort of fuels the non-compliance, the mistrust. And so I think when I came here because I was looking for more public health solutions and answers. And during the pandemic, there was this phrase that I had only heard of. It started during the pandemic, which was food as medicine. And I actually thought and expected that when you're thinking about upstream solutions, that maybe I would hear some of that. And so maybe if you could sort of focus more on a public health approach, and I do believe that medicine has its place. I meet many people who believe that you can treat everything with food. I'm more moderate. I believe it should be a combination of all. And medicine has its place, and it's necessary to get people to a better state of health. But combining lifestyle modifications, I did hear some of that, such as maybe an anti-inflammatory diet. And that's another thing. Thinking about prevention, inflammation mediates 75 to 80% of all chronic disease. But we don't do testing for inflammatory levels. CRP is something that I learned about in research that I've done here at Emory. Treatment guidelines don't recommend treating for inflammation, but if that precedes diseases like heart disease, obesity, diabetes, why are we intervening at that level and recommending something like an anti-inflammatory diet before something develops into a disease? So those are just sort of my thoughts in response to what you raised and the other things that I'm hearing today. So if you could respond to that.
I'll start. Thank you. Thank you both. I have no answer. I think you're spot on. There are time constraints today. This is not an excuse. It's a reason. There are time constraints today that didn't exist back when I went to med school, also for the same reason you did, Jim, because I had an incredible family doctor who was just incredible. And I wanted to be that person. He was almost Dr. Welby-like, if y'all, for some of y'all in the room that remember that. But those constraints weren't there back then. He spent all the time with our family that was needed to address whatever the issue was. And actually, my first doctor was my grandmother. I'm Hispanic, and she was a curandera. She promoted cure through the use of herbs and food and other things. So we've got, sometimes when I'm tackling a problem, I try to go back to basics. And maybe that's part of the solution here, is to go back to basics.
That was an excellent comment, because what I took from that is the point that there's a time and a place for things. Now, when you're ready to fall off the cliff, now's not the time to show you a sign saying, slow down. Now's the time to say, break hard, right? But when you're earlier, you could say things like, you're heading this way, try this anti-inflammatory drug, try this other thing. That by itself foretells a longitudinal relationship, whether it is with a person or a system or the environment around you. Okay? So I don't know that it's an easy thing, and this is where I think public health conversations are just so important. But in some ways, I look at what we're doing in schools. We have these little kids who sit in chairs for hours together to learn. How much playtime do they get? And what's the foods that's served in their cafeteria? Let's start there. It becomes a habit when you start early. And I can't teach or unlearn 50 years of learned behavior if I didn't grow up with it. And maybe it requires a lot of introspection on those lines, but very well-pointed comments. Thank you.
Well, our time has gone quickly. There are other topics I think we could get into, and we could keep this conversation on this panel going, I think, much of the day. I think technology is an area that we could talk more about, predictive analytics, risk stratification tools, and maybe some of the other panels might get into some of those questions. But I want to thank our two panelists for their time, Nitu and Daniel. Thanks so much.
Well, I want to add my thanks to the panel as well. I think as we transition, one of the things that they pointed out, in addition to that wonderful question from one of our students over here, I love that question and the focus of that. But what was pointed out is that we live in a world of what I call short-termism. So we can quantify the costs of an intervention right up front. But what we don't do a good job of is thinking through what are the clinical benefits, economic benefits, personal benefits linked to the intervention downstream. I'll just leave you with the simplest example that I worked on, which is with hepatitis C. Obviously, when it first came out, expensive medication. That's the bad part. Good part is that it cures 99% of hepatitis C cases. Not only that, it eliminates retransmission. So I was having a discussion one time with somebody in the prison system. I said, you should just give it away free. Because at the end of the day, 1, 2, 3 years from now, whatever it may be, you won't have any hepatitis C in your prison system. So we really need to sort of think through that. We're having that discussion right now with GLP medications in terms of thinking through the initial intervention and then what are the downstream benefits. But the short-termism is a real problem that we face, and that's a perspective that we need to change. So we're going to go into our second panel. So I don't, did you want me to introduce him or did you? Okay. Well, this is sort of for me one of the highlights of this conference is to be back together with Jim Curran, who is sort of the father, godfather, great-grandfather of the Rollins School of Public Health. We exist because of what Jim had done in terms of his efforts on the fundraising side to work with the Rollins family and others. And certainly we wouldn't have 3 world-class buildings and sort of the financing model and the faculty that we have without Jim. So Jim went out on a limb and hired me 25 years ago, which is just quite incredible to me that it's been that long. So Jim and Mike Johns have been incredible mentors of mine. So we're happy to have Jim here, who you can see is the Emeritus Dean. He's an epidemiologist by training. He got confused for a little bit. He went to the University of Michigan, but then he went off track and went to Notre Dame, but that's okay. No, we're just really happy to have him here. And we've got a wonderful panel. Unfortunately, Rachna from the CDC Foundation emailed us late last night about a family emergency. Somebody had passed away in her family, so she had to make travel plans. So unfortunately, she won't be able to make it. But we do have three very good panelists. Sharon Berquist, who's the Rollins Senior Distinguished Clinician and Master Clinician and Assistant Professor in Internal Medicine from Emory Healthcare. I'm really excited to hear about what's going on at Morehouse from Rhonda Holliday. She's a professor of community health and preventive medicine, and they've certainly done some great things at Morehouse along these lines. So we're excited to hear from her. And then you are going to hear from Sanjay Doddamani, who's the CEO of Guidehealth, but he's had quite a spectacular background of really working in probably some of the very top healthcare systems in the country. So I'm going to welcome the panel to come up and turn it over to Jim.
Well, thanks, Ken. I've already mouthed off too much, but I'm also chair of the Board of Public Health for the state of Georgia. And I just wanted to mention that, a lot of this issue between public health and medicine is like bringing together two old friends who hadn't seen each other in a long time. When I became chair of the Board of Health, there was one physician in the entire Georgia State Health Department. If you think about that, and 65% of their budget came from the federal government. So when the federal government cuts $12 billion out of state public health funding, and the salaries are so low for public health employees, you can't help but wonder how starved people are to be able to help in the healthcare system the way they would like to be able to help in the healthcare system. But I think that partnership needs to be strengthened. We're really fortunate here to have these three great panelists, and the title of the thing is Perception versus Reality. And we are examining the gaps between the advice patients seek from their healthcare providers and what providers are comfortable discussing when it comes to prevention, behavior change, and lowering risk, which could include intuitively culture differences and culturally competent care. So leading us off is Dr. Berquist.
Thank you. I'll start by maybe just giving a little bit of background about myself, and it will touch on the excellent question we left on with the last panel. So I'm a primary care physician. I've been in practice here at Emory for 25 years. Same longitudinal practice, so very Marcus Welby-like. Same patients who followed me for 25 years over 4 locations. So trust, I really respect and value in patient care. One thing we haven't spent much time talking about is how we're defining prevention. So I'm very much into primary prevention. I do a lot of lifestyle-based prevention. I spend a lot of my time getting patients off of medication and avoiding medication, largely with food as medicine, lifestyle-driven care. I've done a lot of research around innovative programs in primary care and across Emory Healthcare's worksite wellness, such as a teaching kitchen model, a culinary-based model. We've done clinical trials around it, looking at outcomes from instituting these types of programs. We've done cost efficacy analyses, doing these programs in person as well as virtual. And I'm happy to speak a lot about how we can bring some of that innovation into patient care. I also do research on early biomarkers for disease, such as Alzheimer's, looking at liquid biopsies for cancer diagnostics. So I'm very interested in how do we go the furthest upstream possible which actually goes a step even earlier than a lot of US Preventive Service Task Force guidelines. And how do we bring that to the patient? So I do a lot of my work is patient empowerment. How do we help patients help themselves and also bridge that gap with the information and technology that they are getting from the larger sphere that we are working with and where people get their information. So that's a little bit about me.
Would you like to say anything else?
You know, well, there's so much I can say about the gap and the perception of what patients are seeking and what we are positioned to give. There are so many touch points, but I will just start by saying that physicians simply aren't well trained to give preventive advice in the way I'm defining it, which is very lifestyle driven. I've learned almost all of it on my own. And I would love to make this such a routine part of medical education. Things like anti-inflammatory diet, my colleagues have not a very, they're not even familiar with the term, let alone educating patients. And this is the type of information our patients are seeking. People come in asking me granular questions. They are an educated patient population. I work on the Clifton campus. Granular questions about, are eggs good for me? I heard I should have a magnesium supplement. What supplements do you recommend? So I think we could be doing more bridging that gap, because part of gaining the trust is being able to speak on what people are already hearing. And if we cannot answer those questions, I think people are going to seek answers outside the healthcare system. So I will just start out by saying that we could be doing a lot more on building the knowledge base of how we're training people so that we can serve our patients better.
Dr. Holliday, next.
Good morning. Yes, it is still morning. Good morning, everyone. So I'm Rhonda Holliday, and I am with Morehouse School of Medicine. Primarily, my work is around engaging communities and community-based participatory research. And in listening to the panel earlier, as well as some of the questions from the audience, what my focuses on.
There we go.
All right. So what my work really focuses on is how do we build trust within communities? And how do we then provide the community with the tools to really take control or to have some agency in their own healthcare decision-making? And in the decision-making when it comes to their engagement with the healthcare system, their engagement with health providers. So how do you do that? And then at Morehouse School of Medicine, our mission is really about community. It's really social driven. And so as we are thinking about training our physicians, our public health professionals, our physician assistants, et cetera, that focus on community is really important for us. And it's part of the training that they receive. And so building that trust. So it starts with building that trust between the community and the providers. Also teaching our providers how to communicate with community, how to recognize what the community needs, the patients that are coming from those communities, building that competence within them to actually be able to recognize some things that may be preventing them from thinking about prevention. And how do you address that within that healthcare setting? So that's some of the work that I do. I also do some health communications work. So I was thinking about, again, how do we communicate these messages to patients? not only from the patient and provider perspective, but thinking in terms of larger healthcare systems. How are we communicating those messages? And then again, thinking about who those patients come into contact with. It's not always going to be that primary care physician. It may be a physician's assistant. It may be a nurse. It may be someone at an urgent care. But we have to think about all the touch points that a patient may have with a healthcare system and making sure that each one of those individuals has the tools and the competence to really build that trust, to recognize what those patients may need coming from that community, and then to be able to facilitate conversations with patients.
And finally,
beyond introductions, is there a question also that we're addressing at this stage?
I think the general questions about how we can improve communication and information between providers and patients, and the combination of better preparing the providers, but also enlisting the trust of the patients and trying to bridge the gap between the patients and community and providers.
Terrific. Thank you, Jim. And hello, everyone. Well, my name is Dr. Sanjay Doddamani. I'm an internist and cardiologist. I feel woefully inadequate surrounded by two healthcare academic leaders. My career over the last 2 decades has focused on healthcare transformation. I've had the unique privilege of serving in various roles. First, 15 years in academic healthcare and large integrated delivery systems, and then spent time at the federal government at CMMI, and in the last 5 years have focused on a more entrepreneurial role, really to serve as an accelerant for value-based transformation. But I want to draw you back to 2016, when I believe my real healthcare career started, and 8 years before that as well. The first time I was voluntold into a job, it was to run cardiology in a large public hospital in New York. And well, if you looked at that public hospital, they had the worst statistics for acute MI, for heart failure, and other publicly reported outcomes. The first thing that we did is a great lesson tied to your question, Jim, which is how do we improve communication and what really matters to both physicians and patients. And I'm talking about an access as a primary focus for healthcare. Even creating the moment, creating the opportunities for interface between patients and providers has been sorely lacking. 15-minute visits are literally like giving healthcare through a drive-through window. And so we eliminated, for a certain segment of the patient population, appointments, completely eliminated them. It was the most controversial thing, which said anybody with 2 or more no-shows and anybody with this list of ICD-10 codes will never get an appointment again. Instead, they're going to have somebody come out to their home, give them their rights, which is they can come anytime during weekdays and selective weekend hours as well, and that they didn't need an appointment. But had a huge, huge impact. And that led me to my journey to moving on to more complex environments like Geisinger, and then 2016, I went out of the ivory tower of doing LVADs and transplant work and started to do home visits. And I started Geisinger at home. Well, it was the biggest eye-opener in my life about what patients are actually dealing with in their home environments. And I think that eye-opening has led me to understand that we know so little about patients in their environment and what they expect in the context of communication. The truth is, every day, 10,000 Medicare beneficiaries are added. We still live in an environment where 90% of the $4.5 trillion is spent on sick care. And so as we look at and we hear my colleagues here and us talk about how we can improve communication, we need to also think about the future in terms of entering into the digital age, what communication can be redefined as. Thank you.
So we've heard from three people on the panel who I would call terrific public health converts and saints for what they do. And I'm not trying to be too funny. I was trying to be funny, but nobody laughed. But I was thinking that how a transformation of going into the community or listening to your patients' questions or finding out what the community really wants alters your belief in what ought to be done. And then the questions become, how can we universalize your experience to the entire healthcare system and make this kind of communication better? Are there individual provider reluctances? Are there disincentives to communicate meaningfully? Are there just simply inadequate capacity to do it? Or what are the reasons?
I think that some of it is just rethinking how we could be reaching the patient at what their needs are. I increasingly think that the best way we can be doing this work is through team-based care. I think a physician-centric model can only do so much. Access is already a huge issue even for acute care visits to primary care, let alone the work of prevention. And I also think that when we have a team that could include health coaches, social workers, it could include dietitians, et cetera, I think that can really help expand what we can offer through the system. And I think we need to explore these models. I think we need to leverage each person to their ability, but not necessarily assume that the people who are the first point of contact are the ones that can do all this work. Again, a lot of it people simply aren't trained to do. So I think we need to explore more team-based care to meet people where they're at and really understand their needs, meet people where they're at from different communities. And that really begins with expanding what we're thinking of as care delivery.
Rhonda?
So I want to pick up on something that you said in terms of training. So I think it goes back to training. And if we think about how medical professionals are trained. So one of the things that we do at Morehouse School of Medicine is that all of our first year medical students take a community health course. And within that course, it's a 2-semester course. They actually partner with an organization in the community. They go out, they do a needs and assets assessment of that community. They do focus groups, interviews, talk to people in the community to find out what are their health needs, what's important to them in terms of health, and maybe what are some of the pressing needs in that community. And then with all of that information, they actually design and implement an intervention with the community. And so that training there is really, I think, really important in terms of training healthcare professionals to listen to the community. And this happens again in their first year. And so it starts to build within them, I believe, the desire or the proclivity to really listen to community and listen to their patients. Again, we only have, I know I see my doctor, I have about 15 minutes with my doctor. You have to come in and say things rather quickly, but that allows them, I think, to really develop that listening ear and to develop that empathy and that understanding of the communities that people are coming from. And being honest, there are communities, rightfully so, that have that lack of trust in the healthcare system. And so how do you break down that wall and that barrier that patients may come come into that setting with. And also thinking about the amount of information that patients have available to them today, medical information. They can just go online and look up many different things. Some of it is good, some of it is bad. And so there's some pros and cons to that. But they're being influenced by a number of different people now, and not just their healthcare professional. They're being influenced by others. And so being able to really build that trust with patients, addressing their concerns, addressing information that may be incorrect, but in a way that doesn't minimize them or belittle them, is really important.
Thank you, Sanjay.
Yeah, I'm not going to add too much more other than saying the mnemonic that I sort of use is 3TV or 4TV, which is time is probably the biggest constraint and barrier. This perception that you only have limited time with your patient, going through the hamster wheel of 10, 15 or more patients in a given day. Training, which you already spoke about. Team-based care, which you spoke about, and then the other one is targeting. I think we can't be everything for everybody, but we need to be something for somebody. And so when we look at it through that lens, especially from an advanced data science, we heard from Nitu talking about this, the training gaps in motivational interviewing, behavioral psychology, forensic listening, we could go on. And in terms of sort of the big leaps you've seen more recently, and I think Emory's been very forward-leaning in terms of how ambient listening has, put pencils down and given more face time between patients and providers. Those are sort of some of the innovation opportunities that exist today on addressing that. And the last one, the V component of this is values. If you can't resonate with the patient's values, you really ill understand what actual barriers are between the patient and the provider.
So those are the three great answers to the question, and he answered two or three other questions while we were doing it. The one of the questions is the provider, and the provider doesn't have to be just a physician, but whoever the provider is, their lack of comfort with dealing with certain things. So I've spent a lot of my career trying to understand why providers can't talk to their patients about their sexual behavior, about whether or not they're gay, and whether they use any type of drugs. And there's a huge cultural gap between many providers and patients on these issues. And so we see that now. But I've never quite understood why it's so difficult for some of the other things. But it does seem to be. Can you comment on that? Include things like obesity and cancer screening and things like that. Why is there a lack of discussion between providers and patients? And what can we do about it?
Maybe I'll start by talking about something that is a quote from the Emory Healthcare CEO 2 days ago at Becker's, where the question then was about, are we adequately resourced to have these types of conversations? And his response was that even with the resourcing, it starts with a cultural mindset. And so when I think about the several social conditions that you talked about, smoking and substance abuse, and even lifestyle, I don't think that the connections are made, and that we don't have the time, again, going back to the training. So how do you overcome these and actually have these types of conversations? One thing you mentioned was about the team rather than just solely relying on the physician. The other is creating a neutral environment to be able to do this. For example, we recently launched a pilot, and Dan spoke a little bit about moving the MA stars. One of them was using AI agents to go out and do things like fall risk assessments and depression screening. When we looked at some of the data on patient engagement for depression screening, it was actually better than when the humans did it. And so a PHQ-2 is far easier to complete when somebody's not judgmental, when it's an open forum to be able to respond to it. And so I think we're learning about creating the right environments to be able to address essentially what you're largely describing as modifiable risk factors.
I'll add that as I think of each of the things that you just brought up in terms of asking for screening, I think there's a difference between some of these depending on how sensitive a topic they are for the individual. Questions around drug use, for example, a lot of people, the patients have a discomfort disclosing because they're not sure how that information is going to be used. So I think some of it, like I have patients who specifically ask, are you going to document this? And there are ramifications and they are aware of the ramifications. I've had a patient lose life insurance because of a physician who had documented certain things that he had disclosed. So I think this trust issue is a big part of opening that conversation because it's not just a discomfort about discussing per se. It's a discomfort about revealing information that some people hold very private. So things around drug use, sometimes even sexual orientation, are topics that, and mental health are probably topics that people are more guarded about disclosing. And I think physicians also maybe bring up over a relationship of trust, whereas things that are more objective numbers, like this is your body mass index, those are construed to be much more a part of healthcare delivery. Asking questions around behavioral factors like smoking, I think, are more a part of healthcare delivery in a more accepted standard way. So I think the topics we're kind of bringing them all together in one category, but I think we really can break them down because the comfort level is different in some, for example, sexual abuse related questions. I have patients who it may have taken 10 years for them to have disclosed some of that information to me. So it's not sometimes a discomfort on the part of the clinician, it's on the part of the patient and what they choose to share. And again, this all comes down to trust, not only for the provider, but for the system and how that information is going to be utilized.
Rhonda, you're about to say something.
Yeah, so I was just thinking that sometimes I feel like we're having a conversation that doesn't take into account that the providers are people too. And so they come with their own sort of values as well. And so there may be some difficulty for some providers to talk about certain issues because there's not that level of comfort there. For them, it's something that makes them uncomfortable. And thinking about this team-based approach, that may be a good model to address some of those concerns and issues that one member of the team may not be as comfortable discussing. But then again, also thinking about how do you then work with providers or provide them with some training, some education around how to broach some sensitive topics, and maybe even recommending that they speak to someone else about that topic. And maybe we're asking providers to do a lot in terms of their interactions and their interfacing with patients in terms of their level of comfortability. It's something that has to be, I think, that you have to grow into. You're not always going to be comfortable talking about every single topic, but growing in that comfortability and how do we do that and how do we promote that?
Sanjay, I don't want to prolong this, but the things that I sort of tie to what you both said are on having these conversations that are personalized, making sure that they're measurable, in terms of, you talked about BMI, for example, as one of those, or, the number of cigarettes rather than, just, do you smoke? And then establishing some form of socializable conversations around micro goals. Because we all think of going from, A to B, which is you're a smoker, and go to becoming a non-smoker, rather than, finding a path, to engage patients. And that can also mean you going from sort of right at the cause to rather not addressing the cause and going straight to the effect. So, for example, several social determinants also contribute to obesity. And so can you start addressing those? For example, access to nutritious food, food banks, food as medicine, and so on. So I think understanding and learning, and so it really goes back to training and sort of bringing this into the medical conversations that really are creating an environment where you can measure even what is being asked and how they're being responded to establish those micro goals.
We've covered a lot of the issues, and I think one of the things that I've been thinking of, I'm a great fan of the U.S. Preventive Services Task Force, and and I was happy that Obamacare tied together their recommendations with what had to be provided essentially free by insurance companies. That's very much at risk of being pulled back, however. But I've been wondering whether we don't have way too many measures and expect too much of clinicians and patients when it comes to things like trust, for example, and communication. Basically, we're at a low level in our society now in the last few decades of trust. People don't trust anybody. Nobody trusts anything. They don't trust the press. They don't trust the churches. Dr. Salinas gave us an example of who is trusted most, but the answer really would be none of the above would be come in first. And so we don't have trust. And, it would be nice if people had a provider, whether it's a physician or a primary care or whoever, that they could go to if they trusted the person, and they would have somebody to get advice from at least. But that isn't funded very well. And when you have 150 measures or 85 measures of prevention, it's almost like you don't have any. And so what I've been wondering about is whether we could have 2 or 3 things that would be funded like a broken leg, or like cancer, or like a heart attack, that would be part of everything every clinician does. And let me just mention a few of those. Obesity, undetected or untreated hypertension, smoking, and cancer screening. Let's say those are the only 5 things. Maybe throw in alcohol if you want. Those are the only 5 or 6 things that people were graded on. And they were graded and funded on things like obesity. So when anybody comes in, they're all weighed and they all have a BMI. And then the question is, that's a diagnosis. What are you doing for that diagnosis? And how successful are you? And how much follow-up is there? And the patient just knows that. Now, the patient may not like it. They may want to go to a different doctor or something, but they'll be funded the same way. And the same thing with hypertension. And the same thing with smoking. And rather than have 25 of them, I mean, I want people to use PrEP and have condoms and all these kind of things, but that's down the list from a point of view of the whole healthcare system. Any comments on anything else before we turn it over to the maddening crowd?
I would say that, again, if we look at a primary care model of delivering care longitudinally over time, you can't do 180 preventive checks in one visit, but you can do it over time. And I think that's really how to do it. You find the opportunity when it arises that's most appropriate for each of the preventive measures. And these are ongoing conversations. That's how you build the trust. So I think the model is already so constrained where people don't have those long-term relationships, but that's the ideal way where you do eventually get to all, like you can't do it all at one time. And I think each of these are such a rich conversation because let's say we get the BMI, then what, right? Like the system has to be prepared for then what? What resources do I have? If I determine someone's BMI is elevated, then what? Do I have a dietitian that's covered under their plan? Often not. Do I have a gym that I could recommend them to? Often not. So I think when we're eliciting these questions, we need to then be able to offer something. And that's a real issue because if we elicit the question, but then don't offer, people don't think it's worthwhile of their time to invest their energy in explaining to me their challenges if I can't help them other than, giving some personal advice, which, I think we all have different levels of motivation on how much we want to be able to learn and be that resource for the person. So I think we need to, again, look at these questions in the greater context of how are we able to support people, and then ask the question, if we ask about smoking, then what? Do I have a cancer smoking program I can refer them to, or did I just ask the question? So I go back to time. Each of these conversations is people are sharing their vulnerabilities. These are not quick conversations. And if we cut them off midstream, you have just burned trust. So some of it is time and motivational interviewing and not a click. I ask the question. That's how we disengage people. And then the delivery system model, again, it goes back to team-based. Can we do a warm handoff to support them to meet their goals? Not I ask the question and I and the patient are accountable, but there's no path to getting to where the goal is. So I think we need to address these larger questions, not just what should be asked and what are the markers.
Rhonda?
So I wanted to pick up on something that you said about what can you offer the patient. It's also taking into consideration what can you offer, but what do they have access to? Because you can offer something that they may not have access to. And so what does that do to that relationship if I'm constantly offering you something that I cannot access? It may be a start to build frustration to the point where I'm not coming back to you because you keep offering me things that I cannot access. So having the offer is good. Knowing what your patients can access is really important. And that, again, goes back to knowing the community, knowing where your patients come from, having an idea of what they may have access to. Because, again, that's part of that trust building.
The other thing is that emergency prevention is not very well funded. For example, I'm not an emergency physician, but we have at least one here. And what happens if you see somebody who's on opioids in the emergency room? You can't just give them Narcan and send them home. You have to put them into a funded, available treatment program if they're willing to go. But those things aren't that easy to find. And there's a lot of preventive services for people who are sexually abused. A lot of different things just really are not available very, very readily, even if you provide, ask people to do them. Sanjay?
We heard repeatedly from this panel as well as the previous panel about trust, and we also heard the words nudge. What we need to also hear is empathy, which is an important deficit in the fast-moving healthcare of today. But the truth is we're at an inflection point. Not only, when we first heard Dan talk about other OECD nations and where US healthcare costs are, we're literally pricing ourselves to death. And so how do we come back from that? Where do we go, in terms of addressing your question on parsimonious use of quality measures to drive healthcare? I think it starts with the payment system. And so we really need to go back in to recognizing that it's not going to be only fee for service or only value-based care or this direction that has to be accomplished, that we have to get into value-based care. It really needs to be a new age of recognizing the facts, the realities on the ground. We need to recognize that we have very forward-leaning systems that are adopting value, fee for value or fee for outcomes, but recognize increasingly that they need to live in a world of coexistence of payment models. The second is the recognition of omni-channel care, because I can't get my 21-year-old to go to the PCP, but I can get my 21-year-old to do a virtual visit on her phone in the comfort of her dorm to be able to access care. The great benefit is that the baby boomer generation still believe that the primary care physician is the most trusted healthcare advocate. And we've capitalized on that in my company, which is a for-profit company to drive adoption of improving quality and value-based care on the principle of being an extension of that primary care physician relationship. But that's not going to work in the future, when it comes to the millennials who would rather see urgent care or who would rather see, some form of, virtual care. And I want to end by saying, my eyes are on Gloria. So Gloria is not a human. Gloria was a project here in working on a blood pressure gap. One of the health systems that we are mutually associated with here had a 1 out of 5-star blood pressure gap, star measure. And to move that measure to 2 or 3 stars, which would lead to a payment that will also translate to provider incentives, was exceedingly hard. It hadn't been done, in sort of recent memory. So a medical assistant or a community health worker or an outreach call, with 3 or 4 calls an hour would get to maybe 200 or 300 patients in the month, was never going to get that measure completed. And so in collaboration with teams here, we engaged in having Gloria make the outbound call. Well, we were able to do 1,000 outbound calls an hour. And these are phone conversations, getting patients who have a cuff at home to do a patient-reported outcome, straighten their arm, uncross their legs, get a blood pressure reading, and report it. But we only scratched the surface here. We got the measure. It's astounding that we got to 4 stars, and there's a important financial implication. We get paid, providers get paid. So it's a good kumbaya story. But why I say we haven't scratched the surface is now we could use this very powerful opportunity to go to hundreds of thousands of hospital discharges where the last blood pressure was elevated, or patients with, who need preeclampsia monitoring, or others where we can actually escalate into real time with very constrained resources, such as licensed clinical nurses and others, and physicians, so that the right patients, in other words, we're targeting patients better, we're actually moving the needle on encouraging patients to engage in their patient-reported outcomes like blood pressure. And so I think we're at a really tremendous inflection point of what the art of the possible is, but there's going to need to be concerted efforts on sort of using health services research to advance where we are today in terms of healthcare.
It's a terrific advantage to answer one of the questions we didn't ask yet. And that is, how can technology help us? And the other thing I would add to what you say, Sanjay, when you're searching the emergency rooms for untreated hypertension, is the people who are detected get automatic health insurance coverage through Medicare or the Medicaid or the Affordable Care Act. So as soon as they're identified, they're mailed a health insurance card. Now that's idealistic, but I don't know how we're going to do it otherwise, because nobody's going to get paid. And the queries won't go out to those places where people don't have insurance. Automatically, it'll only benefit those haves, not the have-nots. And if we don't do that, then we end up with a class of undertreated people like we already have. Comments from the audience? Panel?
questions? Suggestions?
Hi, everyone. My name is Asia Rivers. I work at Morehouse School of Medicine as well. And throughout the conversation, there was some buzzer words for me that I was hearing, such as trust, access, medical compliance, medical alternatives, and availability. For me and the work that I do, so I work as a program project manager doing diabetes research in rural Georgia. We work with a federally qualified health care system called Albany Area Primary Health Care. And a lot of the work that we do incorporates the implementation of community health workers. One of the projects that I was working on in 2023, we had a 6-week home-based community health worker-led program where we met with people who had uncontrolled diabetes. As we were navigating conversations with these individuals, one of the key factors that came up was availability of their primary healthcare providers, also accessibility of their primary healthcare providers. If you know anything about Albany, Georgia, it is a rural community. So accessibility is a key factor in them being able to be compliant, in them being able to see their providers. Another thing that came up as far as medical alternatives, a couple of people said food and medicine. Albany Area Primary Health Care does a really interesting thing where they prescribe food as medicine initiatives. So the people who come to them who have uncontrolled diabetes, they get a prescription from their doctor, and this prescription helps cover access to food gardens. They have a program called Feed in the Valley there that provides them with food boxes. And Feed in the Valley actually helps to address the accessibility issue because they can take the food to their houses. So to the point of perception versus reality, I do think that it is important that, as you all were saying, meeting the patient where they're at, but I do think that meeting the patient where they're at can be an overwhelming experience for primary care providers because it is a lot. Those community health workers, they had to drive to counties outside of the Albany area because they were reaching people that, were a part of the network, but they may have not lived in Albany. So I do think as we continue this conversation, it's important to see if we are investing in the correct infrastructure because community health workers, community engagement specialists, I don't know if anybody knows about Georgia Watch, but they are in the community doing a lot of great work and trying to get some legislation passed so that they can be a more credible source to help bridge the gap between patient perception, accessibility, access, availability, things of that nature. So just wanted to throw that out.
You mentioned Albany, Georgia several times, and it takes me back to studying innovation, because I think it's been about 15 years on a demonstration project that Phoebe Putney Healthcare System was involved in advanced medical home and the early premier ACO movement. And so I think there's a lot of lessons on scaling out primary care through team-based care that, really started, I think, with one of the early places was in Albany, Georgia.
Anybody else?
Yeah, hi. One thing I want to know is essentially what is the research agenda? And we have someone in research, someone in care delivery, and someone delivering care up on the panel. Where are the innovations going to come from? What are the barriers facing those innovations? Do we know everything we need to know? We just need to do, or what's the holdup?
I would love to explore partnerships with what is happening in the larger space of healthcare. There are incredible, like apps currently that are in use that even a lot of our patients are using that deliver information at the point of decision making for them and help them adopt healthier lifestyles. So how can we partner instead of necessarily recreate some of the solutions that are already out there? And how do we create bridges with the healthcare system and adopting some of that technology? I would love to see some work around that. I think it's very cost effective. A lot of it is delivered virtually. And from our experience delivering multidisciplinary, lifestyle-based prevention programs, we had the same outcomes from virtual as well as in-person programs. So I think that's the best way to leverage limited resources and reach the broadest number of people possible.
So research-wise, I know that there is a lot around using AI, but also thinking about when using AI, who are the models developed from and developed for, and making sure that it's accessible to all communities. So technology is great, but not everyone's going to have access to technology. You have people in rural communities that may not be able to access technology. Also making sure that the community understands the technology and how to use the technology effectively. So again, coming from that community side and community perspective is finding out what the community knows about this technology, how they use the technology, and how we can make the technology better, more accessible for them so that they can have access to what they need, access to the care that they need, to the advice that they need using that technology.
Really agree with Rhonda and Sharon's comments. Sadly, health services research in community care and primary care is behind other areas that are more lucrative or have a shorter time cycle and a path to generating an unlock on revenue and growth. But the beauty is we have a huge Medicare database. We have an annual spend, that well exceeds, $1.8 trillion sitting within that database. There are 11 BRDCs that access and are there for research to be able to conduct them. There are ways to access data, to be able to manipulate data through prize money and through collaborations. And we don't have either the researchers of tomorrow being trained today to be able to focus on driving that kind of change. But we're living in an intensively data-rich environment to be able to support a whole generation of learning.
Sanjay, you mentioned something before about your daughter in her hotel room and how the younger generation has its own source of information, social media, a variety of things like this. And I tend to think of it in too much of a negative way and an irreparable way. But I want to ask you to solve that problem for me. So in other words, people are also learning not to trust vaccines. Vaccines cause autism. Black Americans can't trust the government because of the Tuskegee study, and so you have something like, I'm from the government. Here's a data source. I'm here to help you. Would be the least used social media site in the country. But then the question is, how do we make sure that the app that your daughter's using in her room provides accurate information? And who can certify that? I mean, maybe she gets her information from Joe Rogan instead of from this app that you're talking about. So how can we, we already know ways that people find dates and spouses through dating apps, and they figure out a way to sort out the good ones versus the bad ones. How can we do that with healthcare so that people will voluntarily seek out the most accurate information?
Well, I'm going to just make my comment here really brief. The interesting thing is it isn't just my daughter. It's now my 87-year-old father who's using the internet to counter everything his doctors are telling him. And, he's, buying more supplements that, are questionable, to treat conditions that really do need, prescriptions and pharmaceutical care. So I think we're going to see that it's cross generations and that it's omni-channel. And so that trusted source, how do you restore not just the joy of practicing medicine, but restore the primacy of healthcare information back into the medical profession. So this is going to be a struggle of our time and how we compete with what exists out there, and quite frankly, use those very channels to get to young minds like my daughter.
Yeah.
I had some thoughts about some research agenda ideas that I'll say briefly, and then maybe in the next panel I'll say a little bit more. But this notion that we, to Dr. Holliday's point, take a patient out of the context of their structure, of their home, of their environment, of their built environment, how they can exercise within the community or not. We imagine that patients live in our clinics. They don't. They live in an environment. And so Dr. Ali here had an article about 5 or 6 years ago that really struck me and kept with me, and that's the incidence of diabetes after a partner's diagnosis. And so what your housemate eats really affects your trajectory. And this notion that we take you out of context like you're not living with someone else is very different. So we have to understand kind of the people that are around us. The Beltline around Atlanta is a very interesting idea that's been derailed in some ways, but on target in other ways, to connect Atlanta's neighborhoods with an environment that allows outdoor activity and a safe, not get hit by a car environment. And so what's the impact of that type of infrastructure on health? And maybe one more quick one, and that's here at Emory Healthcare, we did an intervention with the CDC, the great folks at the Injury Prevention Center, who were looking at fall and fall injury prevention to sort of figure out if we can take that model and just embed it in usual primary care and figure out what's going on. And fall prevention seems to work when the patients get the intervention that's recommended. And so there's things that we need to figure out about how do we streamline the identification of the problem to actually getting the treatment. Fall prevention is also taking place in the emergency room when you have people there for a fall injury, figuring out what that next step is. So I think that there are lots of different directions that we can go, but the same kind of like, this is the patient in my exam room. I don't have a better construct or context of what's going on with them. Might be one big picture approach to multiple small problems.
Thanks, Ted. Back to you, Ken. Thank you.
All right, just a couple of quick announcements here before the next panel shows up. One is that we have coming after this panel a 5-star Michelin World Star gourmet lunch. Maybe it's 4.5 stars, but I'm going to go with 5. So that's going to be available after this final panel. So don't miss out on that. And then secondly is that really during lunch and after lunch, we're going to reconvene to sort of walk through what we heard this morning in some, in a working session to really kind of pull together what we've heard, really cut across the different panels and see if we can't come up with sort of one of the questions that Dr. Sia arranged is what's the research piece of this? What's the agenda? What's missing here? What are the opportunities? So I'm going to introduce the moderator for the third panel. Again, a longtime colleague and friend of mine, Dr. Warren Jones. Dr. Jones is the chair emeritus of the Department of Family Medicine at the University of Mississippi Medical Center. He's also the associate vice chair, the chancellor at the University of Mississippi Medical Center. And sort of just to diversify his portfolio, he was also the state Medicaid director in Mississippi. So he has strong Rollins ties. There's a rumor that a sibling of his may be enrolled here. I can absolutely confirm that. So he's familiar with our school and done a lot of work with Dr. Jones over the year, and we're just pleased to have him here to lead our third panel. So Warren.
Hello, everyone. When I heard that nice introduction by Ken, I looked around to see who he was talking about. Well, I do have a strong connection here. My daughter Madison is a first-year student, and I got her permission to call her out. Stand up, Madison, let everybody see you. She didn't want me to signal her out, so but I couldn't help but be here because I've been hearing about places like Moultrie, Georgia, and Albany, Georgia, for the last 40 years, and I just couldn't help but come to talk and interact with folks here about what we can do to deal with the issues we're facing in this section of the world. I'm going to introduce our panel in 1 second, but I want to share something with you. When you look at what the chronic conditions are that we face in the South and the Southeast, I grew up in New Orleans and live in Mississippi. The most common ones that we face are heart disease, diabetes, cancer, chronic obstructive pulmonary disease, arthritis, heart disease, and stroke, and almost 944,800 deaths annually nationwide, and we have the lion's share down here. We're talking about $254 billion to treat those kinds of conditions, and we have the lion's share down here. We talk about diabetes, and Mississippi has the highest rate of new diabetes diagnosed. It's a significant problem. So I hope that what we get to do today with this learned panel that I'm about to introduce to you is begin a dialogue about things that we can do that are actionable and that can be accomplished and can make a difference in people's lives. As I listened to the other panels, I remembered something that I was told a long time ago. Many times patients will leave our offices and not really remember what we said. But then you got to remember, sometimes people may remember what you tell them. Sometimes they remember what you do, but they never forget how you make them feel. So maybe what we got to figure out is a way to have a team approach that gets them to feel that they are playing a role in their lives. And hopefully we can help to begin that dialogue today as a part of what we do. Joining me today on this panel and leading us, of course, in our thoughts on this issue are Dr. Ted Johnson, who is Division Director in General Internal Medicine here at Emory. We also have with us Dr. Brandon Katie. Thank you. I was sitting at the table with him all day and I didn't verify that. Mea culpa, who's a psychiatrist here in Atlanta and very much tied to activities that are going on here at Emory. And we have Dr. Mo Ali, who's here, who is a professor of global health, and I understand a 4-continent prepared individual, and we're looking forward to your insight. And then we also have Dr. Michael Kraft, who's a fellow family physician, and he's also a sports medicine doc and Associate Chief Information Officer. So I'd love to ask our panel to come on up and join us, and let's get ready to get this party started. You know, one of the things that the morning showed is we have a very engaged group of folks here and a lot of information to be shared. So I want to ask you, when you go to lunch, find some time to pick elbow the person sitting next to you, pick their brain and get some suggestions on how you can make things happen in your communities. Well, except for this end of the table, this is one of the better looking panels of the day. You got to excuse this end. But I want to turn to our panel members and just ask you to each say a little bit more about yourself, about your interests and what you'd like to do. And we'll just start straight on down with you, Dr. Johnson.
Great. Hello, Ted Johnson. I have 3 daughters and 3 sisters. And so I'm going to say that the first healthcare provider that I saw as a young man was an insurance adjuster who was trying to figure out whether I would qualify for health insurance. And that's how I found out I had high cholesterol. Otherwise, I never would have known. And so this panel of men can talk about how men don't access healthcare as part of it. And so I'm chair of family and preventive medicine. To an earlier point that we're not trained as much as we could be and should be, I'm going to do a preventive medicine fellowship starting in September. Probably one of the few chairs leaving the chairpersonship to be a trainee. And so I have ultimate respect for House officers and House staff because there's a lot of pre-training to start. I do a lot of my work in geriatrics, and specifically on a micro level, I work in a CMMI innovation center of dementia primary care called integrated memory care. So we're really looking at design of healthcare systems for purpose on a macro level. As chair of family and preventive medicine, chief general internal medicine, I have a role in helping design what happens here in Emory primary care. Over to Brandon.
Thank you.
Hi, everyone. I'm Brandon Kite. I am indeed the dirty word, a psychiatrist here at Emory School of Medicine. I'm also the director of behavioral health integration for Emory Healthcare. And my charge in coming to Emory is to improve patient access and quality of mental health resources through really empowering both providers and patients with a variety of resources that is timely, that's evidence-based, and probably most importantly, sustainable, because how many fly-by-night pilots have we developed that really don't sustain or, gosh forbid, I get recruited by, Sanjay to go work for his company, or I go into industry or the government, that as soon as I leave, these programs fail. So this has taken many different forms, and really it touches upon a lot of the themes we've discussed earlier in the morning. For example, embedding care teams to support primary care physicians and both identification and management of patients with psychiatric and mental health comorbidities. We know that our most expensive patients in the United States that occupy at least 2/3 of healthcare costs are the 1/3 of patients that have a chronic mental health condition and a chronic medical condition. So mental health is health. It's not a byproduct of good health. We really need to be thinking about co-managing it as best as we can. It's also been helping PCPs and primary care get access to expertise in the form of e-consultation, so formalizing that process of curbside consultation so you can have access to the expert. And lastly, it's about how can we leverage emerging technology to scale essentially all that we're doing. Everything from what was mentioned earlier about ecological momentary assessment. Everything I do as a psychiatrist has nothing to do with what's going on in the office. Patients are bringing their life experience, their challenges and relationships, anything that's impacting their psychosocial function. And the only diagnostic I have is me sitting across from the patient, what I'm observing, what the patient is telling me. And if I'm really lucky, I have a family member or concerned family member telling me, or the court system telling me sort of what they've observed or what they're asking of me. And so we really need better tools and better information and better access to information about how our patients are interacting with their environment. And I think that's where there's a really huge opportunity for leveraging technology to do that and integrate into our ecosystem of data that we try to leverage in preventive care.
Hi, everybody. I'm Mohammed Ali. I'm a professor of public health here at the Rollins School of Public Health, and also co-director of the Emory Global Diabetes Research Center. And I spend a little bit of my time in clinic twice a week seeing patients. So it's the joy of being able to sort of see the forest from the trees and zoom out, but also being able to spend time with individual patients and zoom into every individual tree and understand what's different about it. Our center does a bunch of work around diabetes, everything from the biology to the policies that actually change behaviors of people who are either at risk for diabetes or have diabetes. And I could go on for a very long time about all the stuff we do, but suffice it to say, our website has a lot of that information, and I'd love to engage any of you who are interested in it. But just to say from the perspective of the conversations that have been had today, preventive health is one of those really, really challenging things, because I think, and I'll probably comment on this later when we get into the questions, but my view on it is that sometimes as academics, as health systems, we tend to think of it as, what is the supply side doing? So what are we in delivering health and preventive services doing? And is that the only aspect to it? And I would argue actually there's an entire demand side to this, which we don't think about in terms of what motivates people to actually engage in their own prevention. And so it's about figuring out what permutation works, and surprise, surprise, every different permutation probably needs a different answer, which goes against everything we do in public health. But I bet there is some solution somewhere in the middle.
Hey, how are you guys? So I'm Michael Kraft. I currently serve as the Associate Chief Health Information Officer under Dr. Kashyap. Also serve as a Medical Director for Patient Access and responsible for virtual care for the system. and then have a couple other hats. I kind of have an eclectic background, family medicine, sports medicine trained, but also boarded in lifestyle, and I served as a flight surgeon as chief of aerospace for the 920th Combat Rescue Unit for 10 years. And so that kind of eclectic background kind of led me to where I'm at today. And thankfully, I'm part of Emory Digital, again, under Dr. Kashyap, and I get to help kind of redesign how we think to deliver care through our EMR, and how the system starts to engage patients at a system level for preventative measures and overcoming those mountains, because they have been mountains, to get some preventative care out to the system and getting provider buy-in as well as patient buy-in with it. And so, so I was thankful to be asked to talk today, and hopefully we can make some really good headway in that regard.
Oh, great. Thank you all for your introductions and the background about yourself. And Mike, we got something else in common. I used to qualify pilots in the Navy, to give them their waivers. So something else we've got us on both ends. Earlier today, we were talking about what are some of the ways that we can get more clinicians involved in recommending more prevention for individuals. So why do so many individuals, including health professionals, fail to act on prevention, even when they understand intellectually that it's critical to do so? And I'd love to put it out and have you share your thoughts and insights, because that's a key component of what we're talking about today. It's the 900-pound gorilla in the room. How can we get people to recognize the importance, bring it up, and make sure that the partnership is built with their patients to have them want to participate? Anyone? Go ahead.
So I'm going to go back to my supply and demand thing. And I think if it's okay, you think of clinicians as being on the quote unquote supply side of health and preventive services. And I would argue that there's basically a problem of either biology, psychology, or economics. And it's some permutation of those. And so if you think about biology and you think about what is the right intervention for this particular patient, or what is the right preventive care for this particular patient, I don't think it's easy at all, being in clinic, to actually, and for people especially who do the vast majority of their time in clinic, to be up to date with the literature around what is effective for this particular person. And so that's a massive challenge. The psychology piece of it is, what is my incentive to do anything right now? I have 15 minutes. They're coming at me with 20 things that are wrong with them. How do I really incorporate an idea of prevention when I've got a bunch of competing priorities? And frankly, all the data around incentivizing clinicians and saying, here's $20 every time you measure a BMI, have not worked at all, so far as I know from all the data on this. So the second is psychology and incentives. And the third is the economics of it, which is none of us actually knows what is going to be covered for that patient. And I'll give you an example from the diabetes prevention world. Diabetes prevention programs, a lot of insurers are behind them. Medicare has an entire program around being able to cover this. It is a once-in-a-lifetime benefit. So once you've used it, it's gone, which is funny because, I've never seen Medicare stop anybody from getting an antihypertensive in perpetuity, which is also a preventive therapy if you think about it. So we have these double standards, if you think about it, from an economic standpoint on what we will cover. And insurers and this idea of driving a fee-for-service model have not really worked out with what they're covering and ultimately what they're deciding on how they take a risk or not, if you will, on covering something for a patient. Because of churn, most private insurers are sitting there thinking, this person might not be with me next year. Why should I invest in their prevention when they're going to go to somebody else anyway? And the ultimate big pool that everybody gets into is Medicare. So most private insurers just say, let's keep kicking the can down the road, and ultimately the federal government will pick up the tab. So if you think about it, it's sort of a myriad of issues on the supply side. And I think the clinician is stuck right in the middle of it. And so getting them to do anything above or beyond is challenging, I think.
Anyone else? Ted?
I want to go big on the Medicare annual wellness visit for a moment. And so the Medicare annual wellness visit, I went to the national ACP meeting, American College of Physicians meeting. The person next to me said, "Who designed this?" And it is very interesting. I think that it was thoughtfully designed to do two things. One is to gather health risk assessment and to end up with a personalized prevention plan. So those are the two key elements. It's free to beneficiaries. And here's kind of how it's got lost on its way to maybe doing something really good. Most patients come to their Medicare annual wellness visit expecting that it's an annual physical. We've trained folks to expect that every time they'll come in, they'll get an examination and they'll get their annual physical. So it's really an annual wellness and prevention visit. So there's some naming problems there. The other thing is that at least here, we weren't doing personalized prevention planned very well. And we've improved a lot on checking the box that we do it. But the individualized prevention plan is a little bit challenging. So in my work in dealing with people who are living with dementia, it's very interesting what people want. Many of them want to continue to do mammography and colonoscopy. There's this time lag to benefit that doesn't really fit where they might be on their stage of dementia. And so it's really very interesting. What are we trying to prevent in clinic? Unnecessary hospitalizations, unnecessary emergency room visits, and caregiver distress that ends up flipping that patient into some sort of sheltered living situation. So I'll just echo that it's complicated. There's a demand for certain things that may make sense or don't make sense, but trying to be in the care provider shoes and the patient shoes to figure out what it is that they want and how to achieve that.
How do you deal with the patients that go for that visit and walk away saying, "Why are they trying to find out if I'm crazy?"
There is an element of the annual Medicare annual wellness visit that is cognitive screening. And we had a presentation today of someone who is not detected to have a cognitive impairment, who, because of the required element of cognitive screening, did get that. And so I don't think that we do mental state assessments in a very friendly way. We do it in a find a problem way. And there's a lot at stake for seniors in terms of driving, living independently, managing their own finances and such. So I do think that maybe if we do this thoughtfully and in a caring fashion, there are some new approved treatments for early mild cognitive impairment and early Alzheimer's disease that people should know about and make an informed decision. So there is value in finding things and supporting people to do what they can in their life and work.
Thank you. Go right ahead.
Yeah, so I'll just also add, change is hard, right? I mean, think about all the changes that you've tried to make every New Year's, right? With a resolution, and how far did you get over the course of the year? I know we've harped on the fact that, primary care providers have very limited time with their patients, but once you even identify that there's a social determinant of health problem that's driving perhaps one of these chronic risk factors, how do you even begin to tackle that when that's not really a problem that the medical system or healthcare system is well equipped to address? So really, we're very good at building bridges and on-ramps to nowhere, unfortunately, which really disincentivizes and demoralizes, I think, healthcare providers and health systems into trying to tackle these preventive problems. And so not having creative solutions on the back end or mechanisms to hand patients off appropriately to a system or an alternative system of care that can address this notion of change, which is also not a static process. It's a dynamic process. It's more like the stock market. Motivation changes over time. It's not a smooth curve or a linear curve. You're hoping that the trajectory of change is overall that of benefit or improvement. This concept of motivational interviewing, I think, came up earlier in the day. For those of you who are not familiar, this is a well-structured interviewing style to help motivate change and understand where your patient is at in terms of making a decision around change, and helping them really just shift the needle of the ability to change, let alone enact the thing that we want them to do. So I think what we also have is we've got many solutions, many innovative solutions We've got many willing partners who want to deliver those solutions, but we really haven't studied how we implement these solutions in a way that is iterative and that can follow people longitudinally on the scale of human change, which is not an office visit. It's not one annual office visit. It is a many month, many year process that may be deranged by any number of external factors that then leads you to not meeting your incentive that year for that one particular patient, right? So we're not good in the health system and also in the scale of human cognition of thinking longitudinally and trying to integrate these very complex set of life circumstances that drive risk and change. That is where perhaps I do see AI and things like big data to really leverage these opportunities. But it's going to have to be implemented at a scale that goes way beyond, I think, the health systems and healthcare implementation in order for it to really push this notion of preventive disease management.
Thank you. And Mike, your thoughts?
So, my thoughts on this kind of echo a lot of the sentiments that have already been said today. And so, when we're trying to act on prevention, time is a big issue. So, being in the trenches, seeing patients, an annual physical exam, even for those under 65, often turns into a problem-based visit because they have other agendas on their mind and they want to come in and they want to get everything taken care of in, depending on how much time you have, 15 to 30 minutes, 20 to 40 minutes. And so I think time is a factor of that because you also want to make sure that they leave knowing that their chronic conditions or their acute care are taken care of. And then it can be really hard to sometimes get patient buy-in and system buy-in when there's multiple guidelines, suggesting the same preventative care. And so, breast cancer screening is really well known. It's well funded. It's paid for, but you have to start at 40, to start at 45, to start at 50, depending on which guideline you follow from which society. And then it's even more confusing when you decide to have follow-up and it's either 1 year or it's 2 years. And so there's a lot of confusion around preventative medicine as a whole. And I think that leads to, the idea of trust. So Dr. Google or Dr. ChatGPT told me that I'm supposed to get this screening at this age and that I can get it every year. Why are you recommending that I get it at this age and in 2 years, even though they're a low risk, there's no family history. And so I think a lot of those barriers exist to, getting systems, patients, people on board with preventative care.
One of the most disappointing parts of my own personal health journey was showing up to my second colonoscopy to have the endoscopist say, "You're here too early."
Were you like, thanks for the weight loss?
Yes, no, I think that I went forward, and so there is some waste in some preventive services, and so we have to be mindful of that. People getting things that are not indicated, not at the right time, and with all of the value, I'll have to just point on some of the harm. And so one of my jobs before working in the integrated memory care clinic was working at the VA hospital in their continence clinic for older adults. And so we saw lots of folks who had gotten their prostates removed or had radiation to their prostate. And so they were struggling with erectile dysfunction and with bladder dysfunction. And so it's so hard to tee that up properly and meaningfully to somebody who's looking at, I need to get my cancer taken care of, because I think that when I see them 10 years later, they're like, no one ever told me. But if I actually go back, they were told. So there are some harms in some of the things that we do, well-intentioned for prevention.
If I can, I wanted to play off what Michael and what Ted are saying, which is, it's interesting how for some preventive services, cancer as an example, there's demand. People will come in and say, I am so scared. My uncle, once removed, had pancreatic cancer and died in 3 months. What's the screening test? And they hate it when you tell them there is no screening test. Whereas for stuff that's, for example, quote unquote, silent killers like diabetes, like hypertension, not at all interested. They're totally fine walking around with a blood pressure of 160 over 100 because they don't feel anything. And so I think there are preventive services and there are other preventive services.
It's interesting, health systems have a challenge in how to help to build the information about prevention into the process. What kind of recommendations would you make to have systems build in prevention, performance metrics, and accountability so that we can try to get it as uniformly applicable as possible? And it's a particularly challenging question to answer in investor-driven care models, and that's what we're dealing with. I'm a past president of the American Academy of Family Physicians, and I can tell you that almost 80% of our members are now functioning in environments that are being managed by investor-driven care guidelines. So I'd love to hear your thoughts on it.
So I think, as we think about preventative healthcare as a system, we have to have a unified front. And I think that that's one way that we can push forward to start leading some of the EHR abilities. So, a great example within our current EMR is something called campaigns. And in those campaigns, we can do population-driven system initiatives for targeted patient outreach. But some of the problem is that even within our own healthcare system, embedding those recommendations can be really hard because you have different departments wanting to own different parts of that preventative care and having different recommendations. And so I think one way that we can do it as a healthcare system is ensuring or having a task force that's solely focused on preventative health with members from each department that have skin in the game and coming up with an overall recommendation and then making sure that all providers know that this is a system-driven initiative and that we need to push it forward as a system and not allow for people to opt out or providers to opt out because we're looking at population and preventative health, not individual patients. And sometimes as a provider, it's hard to delineate population health versus individual health when you're talking about preventative care.
This certainly gets messy because that initiative rolled out on top of the dementia care clinic in a way. And so we were telling everybody to go get their fit kit in order to screen for colon cancer. And so some of that by age ends up rolling out to people who are moderate or late stage dementia. And so when you get a push from your health system saying you need to do this, and then the context of it is really odd. And if it comes out as a recommendation from the health system, people are looking about, is that a recommendation from my provider group, our nurse practitioner led model? Or is that, what do I do? And so it's challenging. I don't know the right answer. And we're working through some of this to figure out how do we identify people that system-wide intervention shouldn't roll out on top of and which ones should. And as good as our newer EHR is, we don't have that level of this person from a personalized prevention plan. This person shouldn't have this type of intervention.
It's an interesting challenge. Have you thought about maybe how to inculcate class standards in the rollout and the communication, culturally and linguistically appropriate services and communications, and how the role that may play in helping to get greater buy-in for the population you're looking to serve? Typical example, I have a relative that I won't name because my daughter's in the room, who told me for so long about a misery she had on her side. And I got her finally to someone who was willing to take a good history. It ended up being a fungated malignancy on a tumor, and had seen multiple physicians over several years who never dissected what the misery in the side. You got to have culturally and linguistically appropriate communications in order to get prevention and other things taken care of. Have you guys thought of ways to make that happen?
So in our clinic, sometimes we don't really understand what patients are saying, and we don't really understand what caregivers are saying. And at least in our clinic, where we're so focused on what happens to the care partner in order to protect the person living with dementia, that we just have to stay in the room and figure out until we really understand what happened. But what you're saying is an incredible challenge.
Yeah, I would agree. Very hard because, again, culturally, there's very different levels of engagement of the healthcare system. And so, as you do patient outreach, you have to ensure that the patients are expecting something. Because it can, in today's society, an outreach could be thought of as someone's trying to take my personal information. And so I think we have to be very mindful in terms of how we engage patients.
Just one quick one on that. And thinking about team-based care, because a couple of people talked about team-based care and having a whole team, and there are certain members of my team who will be able to find out things that I can't find out, and that we can contextualize that in a way that we can actually intervene and help. Right.
Just to add, I mean, this is not exactly what you're talking about because, but it's one component, which is language barriers.
Yes.
So I'm a non-Spanish speaking clinician who every now and again sees somebody who speaks no English. I will say the system, I think, is of maybe the last year or two made it easier for me, because in the past there used to have to be this, okay, look at your schedule early, let the clinic know we need an interpreter, all these things. These days, I'm not doing that, and the interpreter is just waiting outside the door as I'm ready for that particular patient. So something you guys are doing is amazing, and I love it. And a really specific example of that is that, for example, not only do I find the history taking is far better with that interpreter, but if that interpreter is actually just a little bit engaged and understands that culture better than I do. I, for example, was going through a diabetes patient's diet and talked about bread and rice and other things. And he was like, nope, eating very little. And I was like scratching my head. This A1C is 10, what's going on? And the interpreter goes, and tortillas. And he's like, yeah, 8 a day. And so totally changed the way we looked after him. And it turns out his A1C just needed a few less tortillas.
One of the challenges also is finding the right type of interpreter, because a lot of clinicians think having a family member can aid in that communication, and actually it can be a big problem depending upon the nature of the communication. In some cultures, you can't have a woman sitting in when a man's interview, or a man sitting in during a woman's interview, and knowing the appropriateness of that. And that's why you talk about the culturally sensitive aspect of it. But Brandon, anything you want to add on the process?
Yeah, I had more of a philosophical approach. I think we need to make sure that we're still empowering our physicians, especially our seasoned physicians, to continue working when we say patient-centered approach, but also working from that perspective of the curiosity of the medical student. I think sometimes we lose that as we advance in our clinical practice. And in psychiatry, we talk about a model of care called the good enough therapist. So psychiatrists both prescribe medications, and some of us even do psychotherapy or talk therapy. There's nothing harder when a patient arrives in my office who is of a different ethnicity, a different sexual orientation, or a completely different cultural background from me, and they are entirely disappointed with the fact that I'm the only person available for them.
Yeah.
And so in the landscape, especially of behavioral health, where we do not have an infinite workforce of perfect matches, although perhaps with chatbot therapists that may change, but currently there's none. And so how do you overcome those barriers? And the way I typically approach it is coming at it with an incredible sense of humility and curiosity. Wow. Highlighting the differences as a strength. And this is I need to understand your perspective, and I need to understand you before we can even address this clear problem of obesity that we have. And what are all of those multidimensional challenges? This is very difficult. But I think philosophically, I think that's something that's really important, and we need to think about ways that we can help encourage and leverage that when we have the good enough physician with all of the expertise and knowledge sitting in front of you. We just need to be able to literally translate it. I also do think leveraging technology to help better match patients with better providers is a potential opportunity now. Again, we have large language models that can do a lot of the legwork before the office visit, to have the translator or the interpreter present in the room, or to make sure that the POA family member is present and available for the office visit to provide the collateral information that you need for that patient. It's a very challenging thing to coordinate, but truly care coordination can go a long way towards leveraging and improving those interactions and making them as efficient and as impactful as they possibly can be.
That's a great point to make. And I was wondering, how do we deal with the psychological or social barriers that we have that we often run into when we're trying to encourage engagement in preventive services and things of that nature? Overcoming the challenges of mistrust, as we've talked about, fatalism, misinformation and disinformation. That's just manning the airways. And how do we overcome that participating or worsening inertia around prevention and making a greater barrier for us to overcome? Any thoughts?
Psychology was in there, so I don't know if is that directed, but I'll throw out a couple of thoughts and hand it off to you. We need to again engage motivational interviewing, meet patients where they're at. You know, they're coming with you for information. They've overcome the activation energy of coming to your office, right? So we've gotten that far. Really just being more curious and inquisitive about what is their understanding of the problem, what have they heard, and it's not about challenging a patient's notion or, you know, touting how your medical degree is so far superior to their Google search, but it's really coming at the common ground of how can we approach the next best step in prevention on common ground. And this may not be one discussion, it's going to be several discussions, which may argue for the fact that we need a quarterly preventive wellness visit model as opposed to an annual wellness visit model. The other thing I'll point to is you mentioned overcoming the psychological barrier. We're not good at training not only our physicians, but also our patients. And I think this came up earlier in the day, especially with how much we marveled at how excellent, right, the primary care model is for pediatrics and for children. And I think it really falls off a sheer cliff once the patients leave the pediatric realm. And so there needs to be a lot more legwork in training both parents and pediatric patients about taking ownership of their health and well-being at very, very early stages to survive that transition, but also to make it so that that transition isn't so jarring. So for really setting up transitional care, I think is critically important. I'll also do one other PSA is that I do not think the medical education system does a very good job at training individual physicians to think like population health physicians. So each physician should consider their panel to be their own mini population that they can operate. I mean, we leverage giving providers dashboards with respect to the quality of care that they provide in so much as it ties to their incentives, thinking that that's the only way that providers will really look at these dashboards. But we leverage registries to understand how our patients are doing to make real-time decisions on a weekly basis. So affording physicians time to review their panel in their work week to see who needs to be reached out to, not who's in my schedule for this week, probably would be a better approach, especially towards prevention, and also a better way to leverage health resource utilization, which is so finite and limited.
Just to call it out, inter-visit care is a really difficult concept for health systems to figure out and deal with. And this notion that, well, I did that prevention or screening that one time back then, these need to be continually brought back up again. Inter-visit care is really important.
And since we're talking about the tremendous value that pediatrics has brought to the table, the family home, the medical home concept, it would be a way of making that happen. I'll share a short story. Had a big, tall, scrappy Marine come into my office, and because I'd seen him regularly, I sensed something wasn't right. And as we got ready to close the visit, I usually ended with a handshake. He pulled me close to him and needed a hug. There were some things going on in his family that he did not know where else to turn, but he had enough confidence and trust in me to know that it was safe to do it in our office. It's because we had the longitudinal relationship. It goes to prevention, it goes to acute care, and it goes to the individual care. And I'm just hoping that we can get back to the ability to have that, to do the things that you're talking about. Mike, there was something else. Mo?
So this is actually taking it outside of that one person at a time approach in terms of what one can do in the clinic. Everything that's been said is absolutely correct and should continue. But in parallel, I wonder if we can zoom out and think about prevention from the demand side, from the user who's sitting there thinking, I have competing priorities, I don't know what could be wrong with me. what are my resources to do any of this? There's a real interesting model in South Africa called Discovery Health. And Discovery Health works on the basis of essentially giving you points for doing preventive things. So you get a little card from your insurer, Discovery Health, and when you go to the gym and you swipe that card, you get points. When you go to the grocery store and you buy fruits and vegetables, you get points. And at some point, you can cash in those points for movies. You can cash them in for trips between Cape Town and Johannesburg. Now, where the model fails is that people who buy into Discovery Health tend to be people who like prevention. And so one thing I was thinking about is it would be great to have a Discovery Health type model that was a lot more ubiquitous, and it was not that you could choose to buy in, it was just mandatory for everybody. Because even if you then move people who've got no preventive services going on to a tiny bit, you've already moved the population curve, if you will, a fair amount.
I think these are all amazing points, and I think as we look to decrease the psychological and social barriers for the mistrust, the fatalism in society, we have to lean on community health workers, right? We can look at vaccine programs throughout the world, and when vaccine uptake really started to do well throughout the world is when they had someone going door to door. And I'm not saying that we need to go door to door to do this, but at least having someone who understands the community where there may be a lot of mistrust in there to help create these narratives about preventative care, because right now they're coming with their community's ideas, and that can only be changed within that community. And so I think we need more people in that world helping provide better education and not TikTok.
And that's largely based on the effectiveness and success of the Promotores model that the NIH funded for a long period of time. And actually, even before then, with the Eskimos, the fact that they would send individuals out. So we know that these systems work. Now, the question is, how do we utilize that for prevention? Okay, you can use it when you're going out to treat a specific illness or immunizations, but how do you leverage that for prevention?
Yeah, I mean, I think a lot of it's education and letting them understand that these are recommendations, and there's no malice in making these recommendations or engaging with the healthcare system. But a lot of it's education, not just giving the vaccine or doing that single intervention. But it's going to be a continuum.
To some extent, I think the insurers are starting to do it, but it's sort of haphazard and fragmented between them. But every now and again, I'll have somebody come in with, here's a form that, and it's usually very colorful, which is ticked with half the things ticked and half the things saying you have to do them. And it'll be everything from vaccines to screenings to blood tests. And I'll say, where did you get this? And the Aetna nurse came to my door, or the United Health person came. And I think, it depends on, I'm sure it's not across the board at Aetna. I'm sure it's sort of this HMO plan gets it and that one doesn't, and so and so. But I think they're starting to do some of that. And it gets to Ted's earlier point of sort of intervisit, whether it's community health workers or whether it's insurance companies doing this for their own benefit and their own long-term value. There's a little bit of it happening, I think.
Yeah, I'll just say behavioral economics, what we're talking about, incentivization, is powerful motivator. Case in point, we are implementing a mental health app in one of our clinics, and points towards gift cards at the end of the month for doing your PHQ-9s and doing your psychotherapy homework and things like that can be very powerful. Doesn't motivate everybody. It definitely doesn't. But this is why we need comments about omni-channel approaches. It's not a one-size-fits-all solution for health systems, for populations, or for providers, or even problems. It needs to be a multidimensional approach for whatever we do, and a dynamic one that can adjust to sort of the needs of the patient and the individual circumstance. I think also not only payers and providers, but there are examples of earlier today, there was a discussion about employers, for example, being a major driver of a lot of these change and a lot of these initiatives. And I wanted to bring up, there was a really awesome study done by Aflac and Prudential. So two insurance companies that tend to compete actually came together and conducted a study together called the Workers Left Behind study. And essentially what they were looking at was, what is the impact of a coworker going out on a medical leave on the workers left behind? And the punchline of it was disastrous, meaning the likelihood of a coworker developing a new onset problem that led to them leaving work was almost 2 to 3-fold. And it led to all sorts of decreases in productivity, and it led to decreases in workplace satisfaction and all sorts of other problems. And so what Prudential and Aflac essentially did was came out with a white paper and a position piece about how you can drive and change employment policies around supporting workers, quote unquote, left behind when team members go, that would help support them through that transition. And for us as physicians, maybe you're thinking, well, where do I come in? How many primary care physicians in the room have encountered a patient who comes in with the FMLA paperwork? I need to go out on mental.
All the time.
I need to go out on my mental. Why? Oh, my boss went out, or my coworkers went out, I'm burnt out, all of these things. And a lot of this is the consequences of things that are going on, again, within the workplace. And so, interestingly, Emory Healthcare is the primary care providers for Coke and Delta. We are actually on-site healthcare providers for those two large corporate entities. And so I think another theme that would be kind of interesting, and in terms of my title, integration, right? Co-locating care and bringing care out of these specialty settings. Instead of I'm going to send you places, we're going to embed care or embed access points into community practices, places of work, can really help with a lot of these efforts.
Great. It's good to know what you're responsible for, because you know who to turn to. And you also talked about some innovative things that are going on in some communities by some plans. Is there a role for philanthropy and or private investment to try to create some tools or mechanisms that can help to increase the knowledge of importance of prevention, or motivate people more to be a part of that? Anyone?
We're working with the Arthur Blank Foundation to do mobile prostate cancer screening in communities, communities that have historically not been had available prostate cancer. Prostate cancer screening, incredibly important, so difficult to do in a smart way because of shared decision making, and prostate cancer screening is great for some and not appropriate for others, and follow-up is a little tricky. But at the same time, that's been a passion project at Mr. Blank's, and happy to get going on that within the next month or two.
Great. Tell me if he's got any money left over, send me some in Mississippi.
I just saw that there's a new fine against the Falcons for interfering with Shedeur Sanders on his draft day. So we need to be minding our P's and Q's.
Okay. Randy?
Yeah, I think there's two things I can think of. So philanthropy, of course, I mean, in mental health, it's kind of a hot thing. It has been a hot thing about prevention, specifically around things like suicide prevention. So, the medical model actually serves very well for participating in suicide prevention, and it's critically important. And there's a lot of philanthropic efforts that I've received from every community has a friend or a family member who's either attempted or completed suicide, which has driven a lot of funding for some of the things that we're doing, in so much as how can we improve detection and management of modifiable risk factors of suicide, of which major depressive disorder is one of them. But honestly, it's not the only one. Suicide is actually a very complex phenomenology that is not restricted to patients with depression. So that's one example. On the corporate side, there's been a lot of really kind of interesting things that have happened in the digital mental health space and in trying to sustain it. So January of 2025, CMS went live with their new CPT codes for digital mental health therapeutics, DMHTs. And there's a new group of products called PDTs, prescription digital therapeutics. So these are software as treatment that has undergone the rigors of what a pharmaceutical drug, not quite, but essentially to go through the process of receiving FDA clearance, which doesn't mean that it's a safe or good product. It means that they can advertise on the label that it's a safe and good product. So I think that's important to point out. But anyway, there are these new codes that nobody has any clue about how to leverage and how to implement really interesting scalable technology as treatment in novel care settings. I have companies that come to me and say, I've got this great product for patients with depression. I want all your psychiatrists to give it to them. And I said, no, the psychiatrists don't care about giving apps to patients. Primary care would love to give apps to patients because it's something that they can do at scale. And it's probably better for patients who maybe have a different degree of severity than patients who psychiatrists would be better suited at seeing. So I think there's a lot of opportunity, but there is not a lot on the research side about, again, how do you take the hot new treatment drug technology and go beyond putting it into market, but implementing it in a sustainable way that it can actually improve population-based health and also improve things like prevention and chronic management. So I think there is a lot of opportunity because these companies are hungry to get market share. So,
well,
I don't have much to say about philanthropy because I tend to think that they, unless you can attract them to your area, they tend to work on the basis of somebody in their hierarchy being affected by that condition, which usually drives their interest in a particular condition. So I find it a bit ad hoc. But I just wanted to comment on the idea of co-location and especially amongst big corporations who employ lots and lots of people. About a year and a half ago, we had a World Diabetes Day event, and I called a CEO advisor of our center, and I said, I'm really interested in getting a CEO onto my panel to talk about how bad diabetes is for their population. He said, I hate to break it to you, diabetes is only the 5th or 6th most important thing on their list. And obviously I was very sad about that. But he mentioned the top item that corporates are worried about are days off due to anxiety, days off due to musculoskeletal injuries and other things.
Yes.
And so really, it was kind of interesting to me to hear that. But it also brings to bear that point that corporations really don't want the health of their employees to be better. And so they are seemingly a very good partner for us to think about really actively working with of what will help your employee population. I think that allows you to then do both individual level care as well as population care at scale.
Thank you. Mike?
So in terms of the role of philanthropy and private investment, I think there's definitely a place for them. I mean, I think that, if we think about breast cancer screening and what Susan Komen Foundation has done since 1982 has been remarkable for getting breast cancer screening awareness out. And so I think that there is a role for that, but you have to kind of pick and choose to your point about, we have breast cancer screening awareness, we have prostate cancer screening awareness coming. What are some of the other things that we really need to get out there? And forgive me for, his forgetting his name, but the actor who played Black Panther, there you go. Yeah, perfect. That really kind of propelled colorectal cancer screening.
Yes.
And so I think that when big things like that happen, hopefully there's someone out there who's willing to start to fund some of those initiatives to continue the education.
Great. Now we're going to give a chance for you guys to fire some questions up here. While you're thinking of your questions and you're looking at philanthropies, try to remember that there's something called conversion foundations that may be available in multiple states. Conversion foundation, if you've got a plan that goes from a not-for-profit plan to a for-profit plan, they must create a foundation to carry on public service work. Okay, so think about that as a way.
Georgia, Blue Cross Blue Shield, turned into Georgia Healthcare.
Great. We don't have any of those in Mississippi. We don't have enough people. Okay, but anyone with any questions, please, we've got a great panel. They know a lot. Jim, I'm just excited to meet you. I've heard so much about you, so thank you.
You could have said the opposite. I'm calling on health systems and doctors to get more engaged in politics. Maybe it's because I'm getting older, but I mean, there are two populations. There's a population you serve and in your system or your practice. And I think it's a great idea to be able to look at the outcomes and compare that for priorities and things. But there's also the population of Atlanta, population of Georgia,
And those can be interrelated in ways you don't think about. So for example, what are we doing about people who don't get breast cancer screening in Georgia? Or what are we doing with people who don't get their hypertension diagnosed, their diabetes diagnosed in Georgia and treated? Now, the treatment part of that, if people are diagnosed, can fold into the system. And depending on the economic priorities of the system and their avoidance of the poor, which we see in Georgia all the time. I mean, hospitals close because they only take care of poor people. I mean, that isn't how they say. That's true. But the thing is, untreated hypertension could be absorbed by the health systems, but they has to be diagnosed. The federal government, the state government could do a lot more screening of a lot of people cheaply, but somebody's got to pay for it. It's got to be the state or the federal government, and somebody's got to advocate for it. And a lot of times the advocacy of universities and health systems and doctors is too much tied into financial reimbursement for themselves. I mean, and I'm part of that. I've been part of that for a long time. But how about advocating for CDC closing down their breast cancer screening program throughout the country? I mean, what's the impact of that going to be? How about hiring people who are community trained to go out and screen everybody in Georgia for hypertension and send them into doctors to get treated? How many could we find? And how cheap would that be? Except somebody's got to do it. Somebody's got to pay for it. But instead, we were ready to watch the governor, and I'm sure the Board of Public Health, so don't tell him I said this. But governor can cut back nurses, for example, to make visits. Well, the thing is, we've got to advocate that they don't do that. And if all the health systems in the country, in the state, in Mississippi or anywhere else, came out and said, we demand more screening in outside our populations, and we'll help care for those people once they're detected. We want you to do that, and we want the taxpayers of Mississippi and Georgia and the United States to pay for this. It would have a lot of impact. It might have impact.
You know, it's interesting, Jim, that you would say that. One of the things we said a long time ago was that most of the doctors we know take care of policymakers in their offices, and you can leverage that relationship. But one of the things I found effective in that is not talking politics, but talking policy. I don't ever talk politics with people, but I talk about policies, and I can talk, if you go in Mississippi, I'm respected on both sides of the aisle, because I don't talk politics. I talk about the policy, which we can support with our data, which we can support with impact, which we can support with stories of impact. So I agree with you 100%. And now is an opportune time. Pardon?
It used to work better than it does now.
Yes, it used to, you know, but anybody else want to share anything?
It's harder and harder to figure out what shared values are and shared interests are. At the state of Georgia level, one of the things that we've been able to do is the Georgia Memory Net program that's for early and accurate diagnosis. And basically the plug across the aisle and across all leaders in both House and Senate was to actually not only have these types of resources at Emory, but actually have them disseminated across the state. And so Georgia Memory Net has 7 different memory assessment clinics across the state of Georgia, including Albany. And so this is actually putting, partnering Emory expertise in diagnostics and treatment, partnering with local hospitals and health systems to actually get these services out and near the community with the overall. And there's, I think, 11 departments of public health that'll do telemedicine visits as well as the brick and mortar 7. And so there's got to be, and this is the exploration of shared values. Somewhere there's something that everybody seems to care about. And I love this talk policy, not politics. Thank you.
Yeah. Another example of this was I was part of a lobbying effort 2 years ago that got Georgia Medicaid to turn on reimbursement codes to fund integrated behavioral health. And so the idea here is, yeah, it puts money in my pocket, but really actually what it is it's opening more access to programs to consider integrated behavioral health, especially for communities that largely serve Medicaid beneficiaries. And so I 100% agree with your statement of it's policy, not politics. I'm also a little bit cynical in the fact that I feel like sometimes working with government officials is like working with philanthropy. You have to find the person that has the vested interest. And unfortunately, the motivation often comes and is tied towards who's going to fund or back the next person to run for reelection. So there is a lot. So when you say advocacy, it's not necessarily yelling from the top of your lungs that we need this and mobilizing a constituency. It's also understanding all of the levers and the complexities that are involved in that. But fortunately, Emory does have some pretty good lobbyists that I've interfaced with. And so there are ways for physicians to get involved and to bring these issues to the forefront, to develop good policy that you can try to bring to the House. And so I 100% agree with that effort. It's also not something that's very transparent in how that works and how you can get involved. And so that's probably another area where we could benefit as a
And not to put any pressure on you, but you're standing between our comments and lunch, so I don't mean feel free.
I mean, I'm happy to chat individually, but I think my question is essentially, what could funders do that isn't a series of one-offs? I think you'd mentioned, you could fund breast cancer screening, you fund prostate cancer screening. There is this sense that companies are coming to you, right? They have something that they want, innovation that they want to scale. They want some evidence for it. I get the sense that there is a kind of a dependence on these kind of one-off situations occurring. The system's not set up in a way that all the faculty at Emory would be able to interface with the private sector, with the innovations, at least as far as I understand them. The way that, for instance, faculty, the Emory has a tech transfer office, that faculty, the basic biological sciences, could go to and are encouraged to go to when they have findings that could potentially scale. And so what are the systems that need to be strengthened or created on the prevention and delivery side that could potentially do the same thing? I'll just mention that Emory's been pretty, I would say, sort of on the forefront of supporting these kinds of efforts from the perspective of Emory Digital. For example, I was a recipient of an innovation award, which was essentially a small grant, not a small grant, it was a big grant, to support a novel initiative to implement that would impact the care of patients at Emory Healthcare. If you look at who applied for this innovation award, it was not specific to a department, it's Emory Healthcare wide. The advocates and the leaders for a lot of these initiatives were not necessarily physician driven. They could be physician, administrator, other healthcare professional driven. And so I think there are a lot of opportunities to drive some of these changes. And I think we need to reorient what the research is looking at. It's not about finding the thing that works. It's getting about the process measure of how you implement and sustain it as an outcome measure for whatever it is that you're bringing to the table. So it's insufficient to demonstrate that this product works in a population. What you need to do in order to drive long-term change is how are we going to sustain continued utilization of this new product or this new innovation over a sufficient time horizon where we can demonstrate return on investment, raw reimbursable dollars, something that can actually impact the economics of what this intervention is. And I think that the federal government is really interested in this, or had been historically. They were really looking towards developing grants that also looked at sustainability and health outcomes or economics outcomes as part of the deliverable for that. But it does require having a little bit more foresight and longitudinal support to address and to really understand those outcomes, because those things don't happen on a typical time frame for a typical clinical trial or a study that is looking at efficacy or even effectiveness. Much longer. I mean, think about how we think about revenue cycles, how we think about budgets, how we think about reimbursements, right? I mean, for example, in a digital product or in one of my service lines, I was charged with kind of understanding, what is my revenue cycle? And it took me 2 years in order to really understand what is the revenue cycle, what are the challenges to reimbursement from the payer perspective. I know what I can bill out, but it's a whole different story to look at actually what am I bringing in on raw reimbursement from the services that we've provided.
I'm probably one of the only physicians and definitely the only psychiatrist who actually has regular meetings with patient financial services at Emory. And I actually look at the raw billing, what did we bring in, and actually the balance sheets. It's kind of unique from that perspective, but that was the only way that I can get perspective or insight into actually what is the financial impact of the program that I'm implementing. And that has been really impactful in driving decisions from C-suite to driving decisions around innovation and infrastructure investment into these programs. So I think we do need to bring clinical and economics closer together.
Thank you. Thank you very much, everyone. I apologize. Thank you very much for supporting us today. We appreciate you being here.
So also, as I mentioned, we're gonna do the 4.5 star Michelin lunch, which is outside. If you get a chance, we have a great outside eating area out here. It looks out over the city. So if you want to eat outside, that'd be wonderful. But most importantly, we're going to continue the discussion over lunch, and we're going to reconvene in 25 minutes or so and have our afternoon session that kind of integrates what we've just heard to try to pull together around some questions that we're going to lay out here, what we found in these 3 panels. So go grab a bite, find someplace fun to eat, keep the dialogue up, and we will reconvene in 20 to 25 minutes. So thank you.